which can be seen by the elevation of dominant necrosis factor alpha, oxidative stress, which can be seen in terms of many other markers like the GFAP protein also. And then all this, the central mechanism can all be explained in terms of the insulin signaling deficits. So glaucoma is not merely a ocular hypertension. We know that there are other approaches that can be addressed, and we need to look into that, the complete mechanism of glaucoma in terms of something that might be beyond the intraocular pressure, addressing the intraocular pressure, which leads to one of the clinical trials that we conducted back when I was at Oregon Institute of Medical Sciences. So it was all about the relaxation response. So because we know that the relaxation response, actually when we elicit the relaxation response, we relieve the stress and anxiety and depression. We improve the quality of life, which is one of the very important factors when we treat glaucoma. It lowers cortisol. Cortisol is associated with increased intraocular pressure. Again, we are addressing intraocular pressure by just relaxation response. Then vascular function, because cortisol is associated with thrombosporin A2 regulation, and then also improve central insulin resistance. We enhance brain perfusion when we address the Flammer syndrome and elevation of neurotrophins, and then elevation of parasympathetic activity, which reduces the oxidative stress and immediate excitatonicity and pacifies inflammation. So the basic target components of the stress actually stress and the relaxation response are the genetic, the mutations, epigenetic regulations. We know that mindfulness meditation actually leads to change in the genotype. Actually, the epigenome within 6 hours, 4 to 6 hours actually. So they are clinical because we have seen change in the intraocular pressure, and I will show you one of the cases in one of the ladies when we are with this case study from Germany. In that this lady came to a clinic, and I'll show you the visual fields of those patients also. Then there are certain neurological aspects and psychosocial aspects and the functional aspects, which are actually targeted by relaxation response. So this was a clinical trial we conducted on 160 patients. It was a randomized controlled trial, and then we excluded 70, so we're left with 90 patients. We randomized them in 2 groups. One, there was no change in the medication. The only thing that we did is we did an intervention of 21-day mindfulness-based stress reduction. The clinical trial was actually approved by the Institutional Ethics Committee and approved by the Biosafety Committee also, and the Biosafety Committee and Institutional Ethics Committee, we call it here, they call it IRB, that Institutional Review Board in the United States, and the Germany, at the Magdeburg University in Germany. So we did this clinical trial. So the primary outcome again was intraocular pressure, because we know intraocular pressure is very important, and then there was certain secondary outcomes, cup-to-disc ratio, quality of life, and certain biochemical markers, and rate of oxygen species, and inflammatory markers, and we also checked the whole genome expression pattern using microarrays. So inclusion criteria were actually primary open-angle glaucoma with certain range of intraocular pressure, and will threaten meditation sessions, and patients with normal meditation, and kind of converse in Hindi and English. And we excluded any other comorbid conditions, and there were so many exclusion criteria to try to make the group so much actually similar in terms of demography. So the intervention was actually 21 days intervention, and it was a 70 minutes intervention of mindfulness-based stress reduction. We evaluated the quality of life. That's the WHO breath questionnaire, which has 4 domains. That is the physical health domain, psychological domain, social relationships, and the environmental domain, as well as with another quality of life. This was the general quality of life, and then the vision-related quality of life was the GPL-15, which has the central vision, the peripheral vision, dark adaptation, and outdoor mobility as the domains. And we also did some biochemical assessment, including cortisol, endorphins, ROS estimation, total antioxidant capacity, and gene expression studies to kind of see how cognitive and physiological and genetic aspects match in terms of improvement, if any, we see. And this study was later published in the Journal of Glaucoma, and as you can see, we saw that there was improvement in quality of life. Vision loss, we found that was glaucomatous vision loss, and then we try to give her electrical brain stimulation. As you see, the first two visual fields are like improvement in her vision to some extent, from 12% to 21%, as you can see. But in the second one, as you can observe very well, there was a significant improvement in the vision. This was also a lady, and she had come to our clinic in Berlin, in Germany, and where we treated her, and we gave her two parallel treatments. One was the electrical brain stimulation, and we also gave her treatment with the stress reduction. And you can yourself see the visual field showed improvement. It was marked improvement, and she was very happy with these results. Though we don't see such results in every single patient, we know it's difficult, but in certain cases we do see such results. And there was one more case, which I don't have a slide here, in which there was this young person who was around 40, and he had some problems with the optic nerve, and the doctor again had told him that there's no chance of regaining vision, and we gave the patient electrical brain stimulation, and also in combination with this stress reduction intervention, and we counseled the caregivers to kind of give them a positive reinforcement, which led to significant regain of vision, which was a good news. And we are trying to look into the aspects that kind of would bring these treatments to mainstream clinics. Thank you very much for having me here. On the left is my alma mater. This is where I was trained, AIIMS New Delhi. And on the right bottom, you see the institute where I currently work. Thank you. If there are any questions, I would like to try to respond to the questions.
methodologies by which the caste can be cut, and sometimes it has no caste. For example, if we just regard by recall method, caste can be whatever the person sometime it has no 7 days. At for example, if we just regard by recall method, caste can be whatever the person sometime you have it has no 7 days. Knowledge of for example, if we just regard by recall method, caste can be whatever the person sometime you have it has no 7 days. Knowledge of for example, if we just regard by recall method, caste can be whatever the person sometime it has no 7 days. Knowledge of for example, if you just regard by recall method, whatever the person sometime it has no 7 days. Knowledge of for example, if you just regard by recall method, whatever the person sometime it has no 7 days. Knowledge of for example, if you just regard by recall method, whatever the person sometime it has no 7 days. Knowledge of for example, if you just regard by recall method, whatever the person sometime it has no 7 days.
Personal behavior, personal values are not involved, definitely caste have to be considered. But lot of things like smartwatches can
detect it. Heart rate, you can detect it very easily. So there are some parameters which are not very costly, you can use in your clinical setting very well.
But it seems like it is otherwise. It is then time consuming. Is it so?
Yeah, time consuming, I agree, because you cannot practice medicine like 200 patients in 1 hour. No. For applying the chronobiological principle, you have to record detailed history and you have to debate at least half hour to a particular patient. I agree, it is time consuming and that had to be done because only in my country, in India, in OPD, in busy OPD, the clinicians are devoting time, very less time to one patient, and they had to see a lot of patients, 400, 500, 600 patients in OPD. So that is not serving any purpose. I agree, it is time consuming.
Okay, thank you.
Dr. Shadab, just a disturbed circadian rhythm could be assessed only by a simple questionnaire by asking just 4 or 5 questions. And if you are asking about personalized medicine, then it's cost effective also and time consuming also. But chronobiology itself is not time consuming. Am I right, sir? Because simple questions could answer your queries. So could answer whether you are having a disturbed chronobiology or not. Thank you so much. And now I would request, yes, Farzana ma'am is asking a question.
Good morning. Very warm welcome to all the delegates, speakers, and chairperson for this session, Professor Narsingh Verma sir. I am really very thankful to you for coming over to preside over this very innovative talk by Germain Collison, Professor Germain Collison. Dr. Shadab, I do understand that yes, it is very time consuming. And Dr. Narsingh Verma sir, I agree with you also that in India, where there are so many patients lined up, it is really not possible to spend half an hour on one particular patient in order to be assessing about the chronobiology of that person. So that's why this Department of Personalized Medicine, Molecular and Personalized Medicine has been established here in ERA, and it is unique and it is one of its kind, where we have tried to bring together different aspects of to practice precision medicine under one roof. I mean, a patient who's coming to a clinician can be referred to the Department of Personalized Medicine. Here we are going to have specialized people, personnel who can devote time, who can take that history for half an hour and come to a conclusion, come to an analysis, and who can, then later on, once he forms a kind of a, have an answer to that, or and he can get back to the clinician and then just try to intervene and try to help the clinician to alter the, adjust the timing of the doses of the medicine being given, because chronobiology also, tries to explain as to at what time a particular medicine is going to act, is going to be active at which hour of the day. So not only that you're going to have a right kind of the medicine which suits to that person, as far as the genetics is concerned, pharmacogenetics is concerned, but also it is going to have maximum benefit if you're going to take that medicine at that particular time. So this one new dimension which we have added here and will be starting very soon is this. So Dr. Narsingh Verma, as you are one of the experts, please let me know what as to whatever concept I am having in mind. Is it how much, how far it's going to help the clinicians and for the patient, better patient outcomes. Thank you, sir.
Thank you, madam. I 100% agree to you. Precision medicine, personalized medicine is the requirement of the day. Because you cannot treat all the patient by a blanket method. No. Everybody needs some different approach. And you are very correct that the persons who are trained in personalized medicine or precision medicine, they can devote more time and they can help clinicians to treat patient better and with better results. Here I will like to make two more comments. यहाँ लॉक न करें तो आवाज नहीं आएगी. Yes. And two comments I will like to make. One is you have the Association of Chronobiology, the chronomedicine, and personalized medicine, because chronomedicine and precision medicine in combination will be perfect. Because everybody has its own time for sleep, own time for to eat, own time for other activities. So it will also have a different time for the drugs. Here I will like to quote one thing. One beautiful study is going on at KGMU. Professor MLB Bhatt was the guide at that time with me. I was the guide, he was co-guide. We are treating cancer patients, oral cancer patients, and giving the therapy at that time when the oral temperature or temperature of the tumor is maximum. Because when the tumor temperature is maximum, meaning by that the tumor is growing at very fast rate. Because the tumor will not grow at the same rate throughout 24 hours. No. So when it is growing very fast, the temperature will be more. So on the basis of the tumor temperature, the chemotherapy, radiotherapy is given, then the side effects are less and the particular effect to the tumor are more. That is one study, one PhD thesis going on. One professor in dental wing is doing it, and Dr. Bhatt and myself is the guide. And that has very well shown. Even the chemotherapy, radiotherapy given at particular time, Dr. Bhatt do have one publication in the morning hours versus afternoon versus evening hours. If you search, you will find in Lancet a very good paper that says that the surgeries done in the morning hours versus surgeries done in the afternoon, especially the cardiothoracic surgeries. The problems were more, complications were more in the surgeries done post lunch than in the morning hours. That is because the hormonal level, the blood flow, the circulation, everything has a circadian pattern. So I welcome this department this department will be definitely serving better to humanity. One more suggestion I will like to give you. This department is very welcome. One more department you can start, that is the demand of the nation, demand of the day, and demand of the country, that is family medicine. Why I'm saying that? Because I have been interested that, and I'm doing it in my KG. At present, that department is the need of hour. Because family medicine people are, they are treating whole family under one roof, from children to mother to grandmother to grandfather. They are specialists of all trades. They can treat whole family and they can ask other consultants to help when required. So that will reduce the burden of the major OPDs, medicine with 600, 700, 600, 700 patients, in neurology 800 patients, and out of 800, 500 are only for headache. So they are wasting their time. So the specialist and super specialist can devote more time for those patients who require them. And the general patient, like the patient having the just palpitation and coming to the cardiology, waiting for 2 hours, and all research, all investigations are done without any requirement. So if they can be treated by family medicine experts, but the family medicine experts are very less, you can find them. They
Yeah,
are
sir, definitely, sir. That's a very good suggestion. And soon we will see to it that we also establish this department. So once again, sir, thanks to you, Dr. Professor Rajan Prasad, sir, is sitting amongst us, and we are very blessed to have him with us. He's a very renowned pulmonologist, and he's been recipient of BC Roy Award, and in ERA, he's looking after he's the director medical education, and we are blessed to have him here, sir.
Thank you, madam. Dr. Narsingh Verma, it reminds me when you are saying that surgery performed in the early hours of the day may have a different outlook, may have different outcome. But then if I see the history of KGMU, what I have been told, many of the great surgeons of KGMC are even without KGMC. I see many surgeons, they simply, I don't know why they operate. It is for sake of their convenience, I believe. But many of the surgeons, they do operate in the morning hours. I have heard many good surgeons, they operate at 5 o'clock, sometimes 5:30, 6 o'clock in the morning. So what you said is actually many things are not known, but with the concept, with evolution of all these concepts, chronology, say your chronobiology, your molecular medicine, genomes, whatever we are seeing today, many people are practicing without knowing that possibly. But
Sir,
it
yeah.
might have a significance.
Sir, one thing which you will agree, sir, because you was doing it, sir. If you see if you see PFR and FEV1, morning versus evening, diurnal variation is there, and you have told me that if this diurnal variation is more, then this person is going to develop COPD. You told this. So if the diurnal variation can tell us even before the disease is occurring, that will help us. So in your field, sir, the diurnal variation of these pulmonary functions are the recordings of the PFR, which you was telling that if PFR in morning versus evening, if the difference is more than this person is prone to develop COPD because of the parasympathetic tone. And that we can explain, because now we know that the parasympathetic tone becomes important in asthma. And asthma, you told me that it has a neural basis, not only inflammation, neural basis. So neural basis is because, and you are giving the drugs like tiotropium bromide. It is a parasympathetic tone drug. So that comes to the chronobiology.
Actually, many things people used to practice previously. Now we know their basis. that what was their basis and why it was working more. So those things are now opened up. Thank you, Narsingh.
Thank you so much, Dr. Narsingh Verma sir. And I would request Professor Savitri Thakur ma'am to kindly give token of appreciation to Dr. Narsingh Verma. By the grace of God, I thank God for a successful completion of our session 1. Now I would hand over the mic to Dr. Saleha. So I would like to thank esteemed chairpersons, speakers, and our moderator, Dr. Ghazal Fatma, for the successful execution of the first session of this conference. I would now request all the participants to kindly stay connected since we will shortly begin the inaugural program of our conference at 12 p.m. sharp. And in the meanwhile, we will display a video which will be on our conference and you all can enjoy that video.
Good afternoon. Meanwhile, we are waiting for the chief guest to arrive. We are going to play a video in which we have, tried to showcase all the posters which have been selected in this conference, because this is only a virtual conference, so we will not have a poster walk or anything. So this time we are going to just utilize so that all of you can have a look at all the e-posters. Meanwhile, we are waiting. Thank you very much. Please stay connected.
पोस्टर प्ले कर देना शेयर करोगे
नहीं आ रही? आ रही ना?
ISPMC offers MD, MS and diploma courses in 19 subjects. ISPMC ranks amongst India's top private medical colleges. ISPMC is committed to advanced biomedical research along with the DSIR certification with all departments involved in various basic as well as translational researches. Its Department of Biotechnology is equipped with state-of-the-art central research facilities like molecular diagnostics. There is a fully functional animal house and tissue culture facility which promotes and coordinates various academic and research activities. With the help of intramural funding, several research projects are in progress. Financial grants are provided to the faculty as well as UG and PG students for participating in national and international conferences and for attending workshops and training courses held in different institutions. A number of multidisciplinary extramural research projects are also in progress which are funded by ICMR, DST, DBT, UPCST, etc. The research-oriented approach of EAMC is further enabled by numerous PhD students who are working in the Department of Biotechnology, Pathology, Pharmacology and Biochemistry. EAMC is one of the few colleges to introduce new teaching methodologies in the form of integrated teaching, interactive student-centered learning sessions, skill-based learning and improved methods of assessment of students, that is OSCE or OSPE. Moreover, EAMC offers its students a central library that houses a comprehensive collection of literature and a museum in which excellent specimens for teaching purposes are well maintained. The college houses a 900-plus bed hospital situated within the campus, catering to the needs of poor and weaker sections of the society free of cost. The hospital provides services round the clock with facilities like ICU, EICU, MICU, cath lab for cardiac patients, well-equipped operation theaters, physiotherapy and pharmacy. EAMC is the first medical institution in Asia to have installed Somatin 4 CT scan machine. It is the world's fastest and most advanced CT scan system which can scan the entire heart in approximately 150 ms, faster than heartbeat. The laboratory for stem cell and regenerative medicine at EAMC, the main research objective of our laboratory is to understand the biology of stem cells and how these unique cells may be used in cellular therapies to improve clinical outcome after brain injury. Nescare is our in-house web-based software. It's a unique software as it is purely based on OSCE and OSPE, teaching and evaluation methodology. This assessment style sequentially makes the trainee acknowledge the standard operating procedure of every skill in a given span of time. The college boasts of a 3D animation department that produces medical animation videos to complement the lectures given to students. 3D medical animation explains more information in less time. Video presentations and illustrations.
Good afternoon, everyone. It's my pleasure to welcome you all on behalf of ERA University to the inaugural program of the International Conference. The two-day International Conference of Indian Society of Personalized Medicine, with emphasis on recent advances and challenges, is organized by Department of Personalized and Molecular Medicine under the aegis of Indian Society of Personalized Medicine, with the aim to bring the scientists, clinicians, academicians on one platform so that research that is being carried out in different laboratories can be translated for the better patient care in hospital system. An exciting and informative scientific program is prepared by the scientific committee in which excellent interactive educative sessions by world-renowned experts will be conducted. Total 8 sessions in which more than 24 learned experts from all over the world will speak on disease-based gene profiling and transcriptional and translational analysis, culminating to personalized treatment and management. Moving ahead with the session, I would now take the initiative of welcoming the dignitaries by requesting them one by one to please occupy their seats. But before that, I would like to give a deep thanks to all the dignitaries who have been, who are present here. We wanted to present a bouquet to all of you, but looking into the situation of this pandemic, this was not possible. So sorry for that, but a very deep and a warm welcome to everyone. Can we have a clap for all the people who have taken the initiative of coming here? On the go, I would first request our chief guest, Lieutenant General Dr. Bipin Puri, to please be seated on the dais. Professor Dr. Bipin Puri, Vice Chancellor KGMU. After a glorious 20 years career in the Armed Forces as doctor and serving as Director General of Armed Forces Medical Services and Honorary Surgeon of the President of India, Lieutenant General Dr. Bipin Puri is now heading KGMU as its Vice Chancellor. He is the first Army General to be made the VC of any medical university in the country. He is the recipient of Param Vishisht Seva Medal for his exemplary services in Army's Medical Corps. Thank you, sir. Thank you for taking out your time and coming here. Now next is, we would give a very heartfelt welcome to Dr. Professor Abbas Ali Mehndi, sir, for taking out time and coming here. Here is a short bio sketch of sir. Professor Abbas Ali Mehndi is presently working as professor and head Department of Biochemistry and Controller of Examination, KGMU, Lucknow. Earlier, he has served as Vice Chancellor of ERA University, Lucknow, from 2017 to 19. He is a Fellow of National Academy of Medical Sciences, New Delhi. Professor Mehndi has more than 3 decades of research and teaching experience with 370 research publications having over 16,000 citations, including 25 book chapters. He has written 8 books and has been editor, member of editorial board of international and national journals and reviewer of many national and international journals of repute. Thank you so much, sir. Last but not the least, I would now like to welcome and request our VC, Honorable VC Ma'am Dr. Fazana Mehndi, to please come up on the dais. Dr. Professor Fazana Mehndi is the Vice Chancellor, Era University, Lucknow, and Dean Academics at American University of Barbados. Prior to this, she was Professor of Biochemistry, Era University. Secretary Journal of Society. Her field of specialization includes molecular genetics, free radical biology, toxicology, clinical biochemistry, molecular aspects of metal toxicity, male infertility, autism, metabolic syndrome, and cancer. She has received a number of research grants from agencies like ICMR, DST, etc., and has published more than 150 papers in journals of national and international repute. Professor Mehndi contributes to various professional bodies. She is General Secretary of the Indian Society of Personalized Medicine and Director, Department of Personalized and Molecular Medicine. Today, ERA is synonymous with the spirit of care and service in education. Last year, under the ERA leadership, the hospital worked for COVID patients. The effort were recognized. ERA has received All India Award, Scotch Gold Award, incredible effort during the pandemic. Thank you, ma'am. Thank you for being here. Now comes the introduction of three more dignitaries which are online with us. They have joined online. They are not offline. So starting with their bio sketch. The first one is we have with us Professor and Dr. Rajendra Prasad. Sir, could you please come up and join the dignitaries on the dais? Thank you, sir. Thank you for joining. Professor Rajendra Prasad, Director Medical Education and Professor and Head Department in the field of Pulmonary Medicine in India, like National College of Chest Physician India, Indian Chest Society, Indian College of Allergy, Asthma and Applied Immunology, and Indian Association of Bronchology and Tuberculosis Association of India. Besides several prestigious fellowships of reputed national and international organizations, he was awarded Fellowship of the National Academy of Medical Sciences India, American College of Chest Physicians, USA, and Royal College of Physics and Surgeon, Glasgow. He has supervised about 200 researchers and published 400 original articles, reviews, and book chapters. He also authored 9 books, including 4 books on tuberculosis and an atlas on fiber optics bronchoscopy, based exclusively on Indian patients. He has presented over 1750 guest lectures, scientific papers at various national and international meetings. Thank you so much, sir, for joining. Now coming up with the introduction and bio sketch of all the dignitaries who are with us in an online mode. The first one is Professor Dr. Saroj Churamani Gopal. Professor Dr. Saroj Churamani Gopal is an Indian medical doctor, medical educationist, and considered as the first woman MCH pediatric surgeon from All Indian Institute of Medical Sciences, New Delhi in the country. She is currently the President, National Academy of Medical Sciences, India. Professor Saroj Gopal is a recipient of many honors such as Commonwealth Medical Scholarship 1984, Senior Commonwealth Medical Scholarship 1994, INSA Senior Fellowship, Indian National Science Academy. The Government of India conferred the Dr. B.C. Roy Award on Professor Gopal in 2002 and followed it up with the Civilian Award of the Padma Shri in 2013. Thank you, ma'am. Thank you for joining us online. Next, we have Professor Dr. Hari Sharma. Professor Dr. Hari Shankar Sharma is currently affiliated to the University Medical Center, Amsterdam. Dr. Sharma studied biological sciences at AMU Aligarh and received PhD degree from VP Chest Institute, Delhi in 1984. And same year, he got selected through UPSC to join Ministry of Defense at a captain rank clinical biochemist to serve at AFTC, Delhi, Kent. In 1985, Dr. Sharma received the prestigious fellowship of Max Planck Society and moved to Germany, where he spent 8 years and established a research group of molecular cardiology. He has organized many international conferences, delivered 237 invited lectures worldwide, and received many awards, medals. He is the founder president of the Indian Academy of Biomedical Sciences and Society. Thank you for joining us, sir, online. Last but not the least, we have Dr. Professor Thupal Venkatesh. Dr. Thupal Venkatesh is a professor emeritus at St. John's Medical College, Bangalore. He is CEO and the director of the Foundation of Quality India and the director of the National Referral Center for Lead Projects in India. Dr. Thupal is currently National Chairman of the Indian Society for Lead Awareness and Research. He is also called as the Lead Man of India and was Director of Project Lead Free of the George Foundation, which was instrumental in getting the unlead petrol to India in March 2000. He has served as the National Chairman in getting the Gazette notifications for defining the limits and for lead contents in paints. Thank you so much for everyone, to everyone for joining us online and offline. Now, moving ahead and initiating with the program, we are now having lamp lighting ceremony. As we all know that it is a traditional ritual in India to light a lamp. Light also symbolizes abundance, prosperity, and knowledge. The lightening of an oil lamp is regarded as to bow down to knowledge. With this, I would request our Chief Guest, Vice Chancellor Ma'am, and all the dignitaries to lit the lamp. May the divine power bless us all. I now request all the dignitaries to please take your seat back in the hall, as it is a blended session with both online and offline mode. And now we are going to play a very short film on Era University. Kindly enjoy the video. I would now request to initiate the proceeding to invite our Honorable Vice Chancellor Ma'am to please come and give the welcome address.
Good afternoon, respected Chief Guest, Honorable Lieutenant General Vipin Puri Sir, Professor Abbas Ali Mehdi, Professor Rajendra Prasad, Professor Savitri Thakur Ma'am, and our online participants for this inaugural session. I would like to welcome them, Professor Hari Sharma from Rotterdam, Netherlands, Professor Gopal Chunamani, Madam, Professor Thupil Venkatesh, delegates for this conference, and participants and all the learned speakers. It is indeed my proud privilege to deliver this welcome address in the inaugural session of Second International Conference of Indian Society of Personalized Medicine in collaboration with National Academy of Medical Sciences on recent advances and challenges in personalized medicine, which is being held in Era University, and has been organized by Department of Personalized and Molecular Medicine. The department has been established in the year 2018 with the mission and vision to ensure better patient care by providing early diagnosis, risk assessment, better prognosis, and planning optimal treatment for better patient outcomes. The department takes into account the individual pattern of genomics, dietary and environmental factors for the prevention, prediction, early diagnosis, and prognosis of the disease, and plans for appropriate treatment modalities based on their individualized genetic makeup. As you all know, that precision medicine or personalized medicine has a very unique concept where, while treating a patient, not only the genetics of that particular patient are taken into consideration, but as now we have further advanced, we know that nutrition also plays a very, very important role in not only defining whether a person can develop a certain disease, but also once a person has that disease, how it is going to progress or how a patient outcome is going to be. So along with the genetics, in that department, we are also going to look into the nutrogenomics of that individual. Also, we are going to combine it with medicine. Medicine, as you all have attended the lecture in the morning, that also plays a very crucial role. So, putting together these few aspects under one roof, it is a unique concept, and it is for the first time that this department has been created, and it has started functioning, but due to Corona, we were not able to launch certain programs, which in near future, inshallah, we will be able to start. So that this conference we have organized with the aim to spread awareness about the role of precision or personalized medicine, not only among the clinicians, among the researchers, but also to make aware and educate our general population so that they can understand the importance which it offers. In West, in US and UK, precision and personalized medicine has, they are practicing it, and the patients are getting all the benefits. But in India, it is at a very nascent stage, and we are having clusters of certain research scientists who are working in this field. They are trying to do research, they are trying to publish. Some clinicians are practicing, in bits and pieces, especially for early diagnosis by using molecular or biochemical biomarkers. But in totality, it is not being, practiced. As the awareness is not there, people are not, do not know what are the benefits, how a patient can have a better treatment outcome. So once, by organizing these kind of conferences, once if the awareness is created, and the clinicians will come and join hands with us, because we are basic scientists or researchers who are working in this field. So until and unless they are not going to make collaborations with us, because they are the ones who are receiving the patients. So they receive the patients, and they do the diagnosis, and here the role of the Department of Personalized Medicine comes, that we will help them to diagnose disease early, and once the diagnosis of the particular disease is done, we can help them to suggest medication by studying the genetics of that particular individual. Also, the role of pharmacogenetics is important, as you all know. And not only these two aspects, again, as I had told, nutrition also will be looked into, and use of chronomedicine. So when all these aspects are combined, the holistic approach is going to help the patients. So with this aim and objective, this conference has been designed, and I am very thankful once again to all of you for joining this conference, registering for it from across globe and different parts of India. I would like to specially thank Professor Turamani, Madam, who has given her consent to collaborate with us through National Academy of Medical Sciences. And Professor Rajendra Prasad is here. He is also one of the fellows. Professor Abbas Mehdi, both are fellows from NAMS, so they are representing NAMS. And Professor Hari Sharma, who is the president of the Society of Indian Society of Personalized Medicine, who has been very actively involved in trying to put together the scientific content behind this conference. So once again, I thank all of you and welcome once again. And I wish that you all are going to enjoy this conference and learn, and then share the knowledge, disseminate, bring together more and more clinicians, researchers together, And here I would like to invite all of you to join our society, which is Indian Society of Personalized Medicine. Thank you very much.
Thank you so much, ma'am, for this welcome address and giving us a glimpse. We have online with us Professor Dr. Peter van der Spek, Rotterdam, the Netherlands. He is a professor of clinical bioinformatics of the Department of Pathology at the Erasmus University Medical Center, Rotterdam. Under his supervision, over 30 PhD students successfully defended their thesis. His publication list comprises more than 200 papers in peer-reviewed international journal with an impact factor of 51. His field of expertise includes genetic diagnosis, bioinformatics, and personalized treatment. So I would now request Dr. Peter to please continue with the keynote talk.
Thank you very much. Thank you very much. I hope you can hear me. Okay. Okay, thank you.
Yeah.
All right. So it's a true pleasure to present a session on advances in personalized medicine. And I'm very, very delighted to mention that for long-lasting times, India and the Netherlands are collaborating, and I have been visiting many times your very beautiful country. And together with Professor Hari Sharma, we have organized indeed various events in the context of the impact of personalized medicine for healthcare. So what I'm going to do is give you an outline of how we are applying in the Netherlands this personalized medicine, in particular in Rotterdam, and I'll illustrate this with various examples. So our mission is to bring all these omics technologies towards the clinic. And that means in the clinic we train clinicians, so it is also getting part of their education system to train the doctor of the future who is going to more and more basically apply personalized healthcare. So our mission is to bring omics to the clinic because our vision is personalized medicine is becoming the new way of treating patients. So if that's your vision, you should have a strategy on how you are going to roll this out. And basically, I'm going to try to do is make even the screen bigger for you. I hope you can still see everything.
Yeah, that's perfect. That's perfect.
All right. So the strategy is, of course, to first implement smart molecular diagnostics. And from the smart molecular diagnostics, you stratify your patients into distinct groups, which will be, in some cases, followed by targeted treatments. Now, what we see here is our incredible huge research tower, and on basically every floor they're measuring something else. Now, what's important for the clinicians of the future, that they should realize that they have to pick the right floor to start with their diagnostics, and that's not for every disease the same. And of course, if you want to go towards smart treatments, you need to know what is at the molecular level perturbed, and do you need to use an agonist to activate something, or do you need an antagonist to repress a particular pathway? So knowing what kind of mutations or molecular defects are underlying the disease is very important. Of course, we ask from all our patients that are included in this kind of advanced molecular strategies medical ethical approval, and of course our infrastructure is nowadays ISO certified, so we need to be very, very careful with data, and in particular genetic data. It's very, very protected in Europe, and there's new regulations around, and that's called GDPR, the General Data Protection Regulation. So we also have at the Erasmus University set up a Erasmus Center for Data Analytics, and that has very advanced mathematical and statistical methods, including IT infrastructure, to basically work with large volumes of data and to apply big data analysis, often making use of all kind of cloud solutions. So we see an incredible expenditure of our raw data. We extract from the raw data information, and what we realize is that there's a huge gap occurring between what we understand, our current knowledge, and the information that we can extract from our personalized medicine experiments. We need to translate this into clinical utility, otherwise all these measurements make no sense in day-to-day clinical treatments. So we collect data, even pre-womb to term, so from very early on till very, very late in life, all kinds of events can occur which basically trigger a disease, and this disease could at that stage be treated in some cases. So it's important to know and to diagnose, and that's why we have these molecular tests. We collect the data in 5 different areas, and we store it in a very structured way. So in this way, we can basically reuse the data, and more scientists are being urged to work with open data and to share all their measurements. So basically, I'm telling my students, on Monday I'm doing cancer, on Tuesday it's cardiology, Wednesday is neuro, immune is Thursday, and on Friday I'm doing the pediatrics. Of course, in real life, everything is mixed and is all mixed, ongoing, and being databased at the same time. But what's very important, that with all these molecular tests, you use the same statistical cutoffs, so you can basically make overlays and see connections between different fields. During my talk, I'm going to give you a variety of examples where immune is actually overlapping with a pediatric disease, and actually similar pathways are involved. So health is determined by genetics, lifestyle, and environment. And those different silos contribute not always equally. So for your genetics, you can basically delineate whether you have a particular risk. So you can have a variant in BRCA1, which gives you a risk to develop breast cancer, but it doesn't say that you will actually get the breast cancer. Of course, your lifestyle is very important, and with all these smart devices nowadays, you can start to keep track of your behavior in a much more advanced way than that was possible 10 years ago. And of course, your exposure to all kinds of triggers in the environment is very easier to monitor with the GPSs that are attached onto the phones. So we have large population studies in which we monitor the epidemiology, and also epidemiological data is very important to get ideas about prevention of disease. So by collecting longitudinal data over time, we can see that people who get their first cardiac event, for instance, between age 60 and 70, usually a couple, 5 to 7 years later, after having a poor circulation, actually those patients also tend to develop brain lesions causing, for instance, neurodegeneration, which is very important in order to monitor, of course, what's going on there and whether there is a genetic predisposition or whether there's a physical barrier, etc. Another example is a mother who visits our hospital with a child, and the child presents with eczema. 15 years later, the same mother comes back to the hospital, and now the child presents with a asthma. If we would, at very early stage, sequence the DNA and had found a variant in an immuno-relevant gene, we could have predicted that the patient was at risk for developing asthma. So you could have taken prevention. So the earlier you have a problem, I would urge to go for screening immediately the full genome. And of course, during birth, so right after birth, we do the foot, the heel punch, and check for 29 major genetic diseases. But by checking this, that test costs €250. Now, 380 euro, you sequence the whole coding regions of the genome. So the cost of the heel punch is almost the same now as screening the full genetics of the child. I don't say that with healthy children you should screen the whole genome, but by monitoring in case of medical complications, it makes more and more sense and it's way more cost effective. I'm going to show you another very interesting picture. So you see here 20 different strips. Every strip is a gene. And these are 20 strips reflecting 20 different genes which can cause red skin. Okay. So you see 800 experiments from the top to the bottom, and from left to right you see the 20 genes. So assume you see 20 patients in your polyclinic in the morning, and each patient has a mutation in a different gene. So the first 11 patients have 11 different mutations, but in the 800 experiments you see that the genes behave exactly opposite to the 9 other genes in the other patients that you are seeing. Now, of course, it's totally impossible to see on the nose of the patient which mutation he has. But it's very interesting that once you have mapped the mutations, that you can see in 800 experiments, the gene is red in that experiment, or it's blue in that experiment. And if it's red, it's activated, and if it's blue, it's repressed. So that's the difference between the left bunch of patients and the right bunch of patients. So that's called personalized medicine and stratifying your patients. So we are looking at transcription cascades which are activated or transcription cascades which are repressed. Because that tells you if a mutation in a patient is actually in need for an agonist or an antagonist for treating that particular patient. So the left 11 patients you treat opposite from the right 9 patients. And combining the molecular data that you see on the right with the imaging data that you see on the left is becoming more and more popular. Now, we took the helmet of the Apache helicopter screen, and that costed $500 million, and that was in a military patent. And then we reused that military patent in a healthcare application, and you see here a picture of a ham. And if you scan the ham, you can see the bone with the CT scan. And of course, if you put the screen of the helmet of the Apache helicopter in the operating theater, suddenly you can see the depth perspective, and you can see in the patient on the screen that you have made, the MRIs or the CT scan that you have made, depth perspective. Now what we use for this in true applications in oncology is, for instance, to monitor in 3D the volumetric measurement of a tumor, and this allows you to basically monitor therapy response. Is the tumor over time shrinking or is it growing? Now that's in a 2D scan, very complex, you can't measure or assess this. Whereas if you do a 3D volumetric measurement, you can see it. And also in the pediatric arena, we can apply this to monitor the neck area in order to see whether there is an increased risk in a week 20 ultrasound image of a child that is going to or is developing a Down syndrome phenotype. So morphological changes can be measured in 3D, also in utero. So this technology is now so cheap that's even in your cell phones. If you want to buy a new car, you basically configure your car, you put your phone in your Oculus Rift, you put the thing on your head, and basically you can see how you have configured your car. So technology goes from, in 10 years' time, from $500 million to $500,000 to a civil application. So now going back to medicine. So here you see a stem cell, a neural crest stem cell, and from this stem cell you can develop a neuron, you can develop a glia cell, you can develop a melanocyte in your skin. This stem cell can become a bone, this stem cell can become a teeth. So what's important is that we sequenced a child which had a facial malformation and one of the sutures was prematurely closing, and in our 3D cinema you see here the CT scan of the skull of the child. He's not smoking, this is intubation, he gets oxygen of course by the tube. And we found a mutation in homeobox gene MSX2. So now we need to prove that this is a causal mutation. So we take an antibody, we take a full mouse embryo, and at the right moment in time during development, we stain the whole mount, and we see the suture, the sagittalis lighting up at the skull, and we see expression also in the maxillary and the mandibular zone of the developing face, where will be your teeth elements formed. So that's over here. And we see expression at the AER, that's the ridge on the developing limbs. And that's very important because this factor is also important in regulating apoptosis. And the apoptosis is starting from the ridge in order to separate your fingers and your toes. And what we know in the context of bioinformatics that we want to reuse our data. So a lot of stuff is of course written in the literature, so we tell our doctors, you know what you know because that's in the literature. You know what you don't know, that's why you do your next diagnostic test. You don't know what you know, that's usually in your drawer under your desk, and you don't know what you don't know, this is really scaring the shits out of you. So we can calculate, actually, you don't know what you don't know by taking the measurements. All the genes, the transcripts from top to bottom, are measured week 3, so this is all data, that panel left bottom, is human brain RNA expression data. And this is in utero week 3, in utero week 37, right after birth, 80 years old. Now this blue line is a very important separation. And that separation is once the child is born. And what's very obvious is that a lot of genes are activated before birth and switched off after birth. Things are not switched on before birth and activated after birth. So how does the body know that it suddenly has to change its total repertoire of all its expressed genes? It's driven by oxygen. So you start breathing through your lungs instead of getting the oxygen through the placenta. And that oxygen shift is having major impact on RNA expression. We have actually proven in big data analysis that we could stratify acute myeloid leukemia patients into 16 distinct transcriptionally regulated complexes, and those are either having a good or an intermediate or a poor prognosis. So this paper is published in the New England Journal of Medicine, and it's one of the first papers where true patient stratification is used for therapy decisions. Am I going to put a patient on just a drug which costs €12 at the pharmacy to push the blood cell differentiation when the retinoic acid receptor is blocked, and therefore the differentiation of the blood cell, hematopoietic stem cell, is basically not progressing accordingly to it should be, and either you have to do a bone marrow transplant in the rest of the patients. So these distinct 16 subgroups are very well described in this paper, which I truly can recommend you to have a look at. Another application is in melanoma. You see different mutations which are important and linked to a different choice of therapy. So either you have a mutation in BRAF, RAS, or NF1, you select the MPK inhibitor. If you're triple wild type for those 3 genes, you actually go for the RTK inhibitor. Now what's going on there? So this melanocyte is residing in a layer of the skin. Okay, once those cells start dividing, you basically see that they grow in a radial growth phase, so with the tissue layer. And the next step of the melanoma progression is that it goes vertical growth phase, so it starts breaking through the tissue layers. And the major difference between radial and vertical growth phase is that the suppression by cytokines of your immune system is lost. And if the immunosuppression is lost, basically it starts invading through the tissue layer and it starts metastasizing. And that's bad news. So the gene SPINK5 is known to have a role in the immune system, but it also causes a very rare syndrome which is called Netherton. And Netherton patients have red skin. And if you look in primary melanoma patients, you see RNA expression of SPINK5. But in the metastasized melanoma patients, you hardly detect this SPINK5. So that's very suggestive, and potentially we can use this as an informative marker. And what we see here is early versus late, and there's a second gene, KLK7, which has an exactly similar pattern in the RNA expression data. That's pretty suggestive. And a third gene, filaggrin. So what is actually happening is that filaggrin, KLK7, and SPINK5 are forming a complex. And you can if you monitor very clearly, you see that those two patients are the same as those two patients, are the same as those two patients. So there is an exactly same order in how the patients were sorted from the top to the bottom, and we see that this biology is truly informative in monitoring disease progression of melanoma. So integrating information across integrating data across different types of experiments is very important. So taking RNA expression, proteomics, drug treatment information, and literature and pattern information, integration helps you in making the right decisions. 4% of the healthcare costs in the Netherlands are spent on diagnostics, whereas 72% of what we do in the clinic is based on this 4%. So if a human genome costs $1,000, now I'm going to help you, it doesn't cost nowadays $1,000 anymore, it costs in 2021 only $350. So the ultimate genetic test in week 1 can be very cost effective, because after that you can do a lot of digital lookups over time during lifetime progression, where in the past you had incredible high cost-driven experiments, where also genetics were being applied, or molecular tests which you can delineate from your genome. So we are comparing bikes, and half of your DNA you get from your mother, and the other half you get from your father. And human length is genetically determined, that's why the seat varies in height. And we look for non-functional changes. So if the bucket is upside down, you cannot take your bag. All right, this is genetics for dummies. So this is how we compare the genomes. And now we get the more complicated version. If we print one patient, its genome, that's 250 kilometers of paper, and that's one genome. And then we are going to look for one typo in the 250 kilometers of paper. So you better use a computer to find that typo, otherwise you're retired before you have solved case number 1 in your career. So filtering and smart filtering across healthy individuals and diseased individuals is very, very key. Of course, knowing whether you have a loss of function or a gain of function is also very important. And now I'm going to say a couple of things about an important immune factor, which is called STAT3, which actually binds to a craniofacial bone-related gene, interleukin-11RA. So there is true protein-protein interaction between interleukin-11RA and the immune-relevant STAT3 protein. You can have either a gain of function or a loss of function in STAT3. If you have a gain of function, you get hyper-IgE syndrome. You produce a lot of IgE molecules. But if you have a gain of, so this is the loss of function. If you have a gain of function, as the mutations which are in the bottom part illustrated here can cause, you get autoimmune diseases. And so here you see more clearly summarized, the gain causes the autoimmune, the type 1 diabetes. The loss of function of STAT3 gives the recurrent bacterial infections. But what they also present is with facial dysmorphism. And this was striking to us because we were just sequencing 300 craniofacial patients, and we had a lot of research ongoing in the facial area, and we discovered interleukin 11RA. But meanwhile, we were also sequencing patients with immune disorders, and weird, we found overlap in pathways. And that was just coincidental, but from our autoimmune to auto-inflammatory diseases, we found also that the patients often look more like each other than they look like their family members in the autoimmune space. And that was illustrated by broader noses, etc. So this picture shows you all kinds of balls. And the balls are connected by the genes that are mutated. It's a very interesting PNAS paper, and I really can recommend you having a look at this one. All the blue balls reflect cancer. And what was striking to us by looking at this paper was that behind the blue balls were pink balls. And all the pink balls were craniofacial diseases. And we have just sequenced 300 families with affected children with craniofacial disorders. The genes that are actually involved are fibroblast growth factor receptor number 1, fibroblast growth factor receptor 2, and fibroblast growth factor receptor 3. Those receptors are sort of switches on the cell membrane, and they cause these red illustrated diseases as congenital diseases because all the cells in the whole body have the same mutation. But those same factors appear to be involved in cancer. That means you get an acquired mutation in one of those switches, which actually makes your transcription derail. And that's why we see, for instance, FGFR3 in Munker syndrome, with FGFR3, so germline causes Munker, somatic mutations cause bladder cancer or breast cancer. And here you see other examples of cancers triggered by FGFR3 and in terms of their frequency, and you can actually see the contributions to these cancers by FGFR1 to FGFR3. Moreover, nowadays people start looking at stem cells. So we can do single cell RNA sequencing and we can monitor all kinds of cells and which genes are active or repressed. And what we see here we looked for FGFR3 in our single cell repository. We see it lighting up here in this group, which is really pointing to the radioglia. And actually what we see here is that astrocytes are very clearly expressing this FGFR3. This is very interesting because the glial cells also are derived from the neuropressed stem cells, so it fits perfectly well. So immunotherapy is getting more and more on the radar for personalized cancer treatments. In the normal situation, your immune cells clear the damaged cancer cell. You get older and you, at some stage, are going to reach a sort of equilibrium. And then, in some cases, once that you get a mutation, the immune system is not recognizing the cancer mutation anymore. This is pretty alarming. So you get your primary tumor. In order to prevent your primary tumor to metastasize, you want to increase the activity of your immune system. And that's basically what's happening with all these PD-1, L1 inhibitors, etc., is that you basically activate the immune system in order to basically go back to the original situation where the immune system is higher active than the cancer cell, and the immune system can clear out the cancer again. So the current situation, we spend this red box on diagnostics. The new situation, you're going to do more diagnostics, and you want to keep your healthcare costs the same. So that means you have to become more efficient in your treatments, and that's only possible once you start to go towards the targeted treatments. So for our students, we tell, realize, think, learn, and don't be afraid because the technologies evolve very fast. So we embed personalized medicine in our teaching program. We are talking to the insurance companies about reimbursement of those new molecular diagnostic tests. And of course, we talk to the Ministry of Healthcare in order to have the legislation and regulation in place to be able to apply the techniques. We encourage open data and reuse of data, but we have to be careful with the GDPR regulation. Of course, once you start to publish photos of your patient with facial malformations, you can recognize them in the metro, and that's a privacy issue which is not allowed. So we have seen examples of combining molecular with imaging technology. This gives the new opportunities for disease management. And with this, I would like to close my talk and open the floor for some short questions. Thank you very much. And I really would like to thank Hari Sharma, who you see here on the top left, who is bringing not only the Minister of Healthcare, but also our Prime Minister to India. And fortunately, this small guy, being me, was even taken to a famous Taj Mahal, which I'm very privileged to have seen due to Hari, who organizes very interesting conferences in India. Thank you very much.
Thank you so much, sir, for the beautiful talk. I would now request the audience and the participants present that if you have any queries, the sir is there to reply to the same. Any queries from the audience?
They all go to the Taj Mahal.
I think it was amazing talk here.
Thank you.
Fantastic.
Okay, let us ask one question. So you talk about that PDL1 is being regulated by this post-Jet one being regulated by immunomodulators. So how they are cross-connected?
Yeah, that's a very good point. So, we need to try to go back. So what was becoming very, very clear to us when looking at conditions in which you have recurrent bacterial infections, so it's your genetic patients which usually are more sensitive and therefore very informative about the activities of particular biochemical pathways. Now there's step 3, you have step 1, which is very important in recognizing infections. So HPV in cancer, step 1 is going up. Step 3 is way more bacterial infections. What step 3 was doing is actually, if you have over, so gain of function, so too much activity of step 3, it binds all kind of transcription loci and is starting to activate a whole bunch of genes. But what's a very important problem in those patients which have overactivity of their immune system is that they start with their immune system to attack their islands which produce insulin. And that's a very important thing. So if you have a basal, too high level of your immune system, you're starting to damage your islands which produce the insulin. And the autoimmune enteropathy is causing a problem of the immune system in the gut, but it can equally occur in the lung or in the joints. So the immune system is basically the whole time the signaling molecules throughout your body, and once you have eaten, what's happening? Your liver gets activated because your digestive system has to become active. So the communication between the organs is run through the bloodstream. And this is why we are monitoring in different organs what are the changes, but also over time in a 24-hour. So I heard this morning a talk on the chronobiology. Now, this is very, very important in terms of pharmacogenetics, kinetics, and also effects of regulating sleep, digesting food. So that's all regulated through the immune system. So subtle imbalances in the immune system are affecting multiple processes. And you have to see the body as a really complex system. So it's not just one gene which you try to basically perturb, but you really need to see what is the effect of perturbing or using the immunomodulators and what are the major complaints of the patients. So, but anyway, we for instance have been looking at proteins with a somologic scan, so you can scan in the blood of cancer patients who get for lung cancer immunotherapy. So what we see with nivolumab after 3, 6, 9 months, we can already see that in the blood after 3 months there is a whole 30 proteins clearly changed if you are a responder for nivolumab. Now nivolumab is a very expensive antibody-based drug, immunotherapy. So it works only in a subset of patients. So if you can see after 3 months that the patient responds, instead of treating him for a year with a very expensive drug, you rather stop after 3 months if you don't see the 30 proteins coming up. So this is what I feel is typically a personalized medicine discovery, where you're only going to treat in the future the patients who express those 30 proteins. So we look at those lung cancer patients which we treat with immunotherapy, and we look at the immune response in relatively easy readout with the somologic scan on the blood, because just drawing a tube of blood is, well, it's invasive, but it's not so very invasive. So I hope this really answers your question, and in view of the time, I don't know.
Thank you so much. Thank you so much.
Yeah, okay, please.
Insightful response. And now we are going to move ahead with the session. I would request our chief guest, Lieutenant General Dr. Bipin Puri, Honorable Vice Chancellor, KGMU Lucknow.
Thank you, Peter. It was wonderful talk.
Please come up for an inaugural address.
They live, because according to the great philosophy, everything affects the progress of the disease, the ultimate outcome of the disease. And therefore, when we are studying the genomics and the personalized medicine of tomorrow, we must also keep on storing, hardening this information on the supercomputers so that this is analyzed beautifully well and scientifically well, so that once we come out with what happens at the molecular level, we must also know what happens at the phenomenal level or phenotypic level, because it is the phenotypic level which can be understood by majority of the public as well as by the majority of the doctors, and could help the patient in masses. I'm sure this particular conference which is being held will be eye-opening to all of us, and will serve the purpose of opening the efficacy of personalized medicine in times to come. I'm very indebted with Dr. Peter, who gave a very elaborate key lecture in this conference, and I wish this conference a very great success. Thank you so much.
Thank you very much, madam. Thank you.
Thank you so much, ma'am. Now next online we have another speaker with us, Professor Dr. Tupul Venkatesh, Emeritus Professor, St. John's Medical College, Bangalore, Director, Foundation of Quality, India. Sir, could we please have you here?
respected Professor.
He is not present, so online he is not there. So he has sent us a video. Kindly, video is being played. Now you will hear the video.
Sir Farzana, I am extremely delighted and feel proud and happy to be associated with Indian Society of Personalized Medicine. In fact, it gives me, apart from personal satisfaction, I find that the conference which is being planned is of great global importance. My personal view that the future of healthcare system will be mostly around personalized medicine only. This has been accepted worldwide for two reasons. Number one, to minimize or to avoid any side effects of toxic drugs. We know that every drug which is used for any kind of treatment is considered toxic. At the same time, the second reason for going in for personal medicine is, at present, whatever medication which is advocated, even in the most sophisticated, modernized hospitals, is for the entire system, not to a particular organ or a tissue or a cell. That means the cost of medication is also quite enormous when you look at the country level production of pharmaceuticals, the huge quantity involving a lot of investment and expenses. How much of it is really required to treat the infected or injured tissue? This is a big question. The personalized medicine is more focused to a point of care treatment. The point of care treatment is the drug should only reach that particular organ or tissue where there is a pathology and it should correct it. In this direction, I am very happy to find this conference which is planned involving experts from all over the globe to discuss. In fact, the outcome of this conference, I am sure, will be a guideline. I am sure it will be some kind of recommendations to even general practitioners to focus on personalized medicine, to minimize unnecessary medication, and to improve the economic status by reducing unnecessary expenses. And this society, which is formed to disseminate knowledge and promote academic excellence in the field of personalized medicine, is doing human work. And I must here recall that this personal medicine is not new to us. If you see some of the traditional medicines, ancient medicine system, whether Chinese medicine or our ancient herbal medicines in our Ayurvedic system, they are all more or less personalized. The physicians or Vaidya used to take history of the patient in detail, and then he used to prepare the medicine, and he used to prescribe the time at which it should be taken, and he used to advocate, and he used to tell this medicine is only for you. Any other person in your family having similar symptoms may require different dosage and different timings and different medication. Therefore, this is the, maybe the history tells us that personalized medicine existed and continue to exist. However, in modern medicine, this needs to be
implemented with the peer-reviewed studies, cohort studies, and also to save recover the sick organs, sick cells, and sick tissue. I'm sure in days to come, in years to come, when we go to a clinician or a healthcare professional, we will not treat the other healthy tissues, we only treat the unhealthy component of our system. I am sure this will take all of us to a beneficial era. Thank you very much.
Thank you so much, sir, for your speech. Now, last but not least, we have Dr. Professor Harish Sharma, Erasmus MC University Medical Center, Rotterdam, the Netherlands. Sir, I request you to please continue with your speech and would also request you to deliver a vote of thanks as soon as you finish your talk. So, sir, kindly come up.
Yeah. Thank you.
Thanks.
Can you hear me on?
Yes, sir. You are audible.
Yeah. So, we have witnessed an amazing start of this special conference. In the outset, I would just convey that one way comments conveyed by our Secretary and the Vice Chancellor, Mrs. Farzana Mahdi, but this is something very unique which we are embarking on in India, and we want to really be a kind of success story in relation to the personalized medicine, because that is the future. And then we are in collaboration with multiple centers, and especially the one which I am associated now at Erasmus Medical Center, as Professor Van very clearly mentioned, that we have multiple floors and you can just walk into one floor and then learn what is going on in relation to the personalized medicine related to various diseases. So I will just convey quickly thanks to many of you, and particularly the Chief Guest, Dr. Puri, coming all the way from KGMU, taking some time out. I can imagine due to the new surge of corona cases rising in India, I think everybody is much alarmed and everybody is much worried and planning and reimposing the restrictions. So I can imagine his busy schedule, and one of our best friends, Dr. Mahdi, who is instrumental, he is an amazing, highly motivated, positive individual who not only a great scientist but also a great human being. Together with Dr. Puri, this was wonderful. Thanks for joining our annual function. Many people, those who could not really physically represent Dr. Venkatesh for a wonderful intro and his word of wisdom and his blessings for the society. Dr. Rajat Prasad, who is known to me for many, many years and also being the director of my alma mater, where I did my last degree from College Institute in Delhi, one of the pioneer, and had the privilege to work there. The renowned physiologist, Professor Avtar Singh Painter, irrespective. I know friends all over the globe, and particularly I'm indebted to Dr. Brown, Dr. Gibson Brown, this man. He has been witnessing us starting the conference. I want to say thank you so much. You are one of my long-lasting friend. Whenever I'm asking to join us, you are there. And now, and your research has been, outstanding work which you have done using the food as a medicine, which is also part of the breast medicine. I think this is amazing work, an excellent, guided extra young boys, those who would carry, forward. I'm very much sure, and your contribution to Indian academics is enormous. And I won't forget when you came for the first time when you traveled to Lucknow by train from Chandigarh, and after reaching Lucknow, because we were having the overnight journey from Chandigarh to Lucknow, and I usually, I lived from India for almost 40 years. I haven't traveled with the trains, and I drove the overnight train. As soon as we landed in Lucknow, we both basically you were too strongly became diarrhea, and we were so weak, and I also and we had to rush for the doctor, and then we were really worried. But I think the hospitality of Lucknow is really unmatchable to the world. The people reached out and helped us, and we were there up for the conference, and was also in KGMU. That was a conference which was chaired by Dr. Mahadi. I think about 15, 18 years ago or something like that, at least. At least. I'm sorry. Thank you, Lindsay. Thank you so much. I thank everybody who has contributed, particularly in putting together this program. The entire team of Dr. Faizan Ahmadi, they were working day and night to decorate and prepare and get in touch with everybody. Now with WhatsApp, telephoning, and writing mails and all that. So the huge team she has. And really dedicated people. Thank you all of you guys, the technical staff who has been instrumental in arranging all this, video conferencing with all of us, those who are not able to be there physically. And I think in this pandemic period, it's wise that we can interact by video. And be, part of this academic feast. Madam Kamaraman, a very senior scientist from Lucknow, very reputed. Madam, I have seen you in many pharmacology meetings. I'm almost last 25, 28 years. Thank you, welcome, and thanks for joining us. And many faculty and many, my friend, Dr. Venkatesh, many friends from Erasmus, Peter was there. And I must really emphasize the collaboration with National Academy of Medical Sciences. I had a word and also a letter written to Madam Professor Joan Maniji, and she was very positive and enthusiastically saying why not we should be part of it, and because this comes under their also one of the objectives to share the medical academy vision with many other societies. And so the Personalized Medicine is very much thankful to that we are collaborating with NOMS, and we are continuing this 2 days conference this year, and we would like to thank the President, Madam Chouamani, as well as the entire Academy, National Academy of Medical Sciences. And I think with this, if I have missed some specific name, my apologies for that. But let's continue with the academic feast for the next 2 days and share our experiences, share our work which we are doing with the young minds sitting there and online, offline, and let us be the part of the human well-being and share our knowledge and experience also in this ongoing COVID-19 pandemic, which is a tremendous challenge for the humanity all over the globe. So thank you very, very much, all of you guys. Thank you very much, and we can continue. And I would like to hand over the floor to the moderator who is continuing. Thanks a lot. Thank you very much, Dr. Sharma, Professor Sharma, and I must quickly congratulate Fazana for organizing such a wonderful conference. We are proud of Dr. Fazana. Good night. Thank you, Vaktesh.
Thank you so much. With this, we come to an end of our inaugural session. Thank you to the special thanks to the dignitaries and the prominent speakers. And
Thank you, Dr. Saleha, for the moderation of this inaugural session. As the Vice Chancellor was busy and he had several meetings which were called by the administration in view of the pandemic going on, as the second wave is just round the corner. So all the schools, the colleges, even the universities, just today at 11 o'clock we came to know that the universities have to run all the courses online except for the medical and the nursing. So the Vice Chancellor had to rush back. So but at the same time he has expressed his appreciation for this conference. And Madam Churamani, I had just gone to see him off as he was our chief guest. So thank you once again, Professor Sharma, Professor Tupul Venkatesh, Professor Churamani, and all our respected delegates and speakers from all over the world. Professor Lindsay Brown, Dr. Kamar Rahman, she's been one of my teachers and mentor. Thank you, madam, for such kind words. It is your guidance only under which we all learned in ITRC back around more than 30 years with your blessings. And Professor Hari Sharma, he's part of the family and he's the president of the Indian Society of Personalized Medicine, and various other delegates who have joined this inaugural ceremony. Now it is coming to an end, but at the same time, the oral session is being, the award for the oral session the function is going on, and on the Zoom link ID B, parallel it is running, and meanwhile we are going to run a video of the abstracts for the oral session in this Zoom ID link A in this hall. So thank you very much. We will break for some time. You all can see the video of all the oral abstracts which have been selected in this conference, and they are being judged. After that, we are going to declare the winners. And meanwhile, we are going to be back with the next session at 2:30. So please join back and stay connected. Thank you very much.
I would request Dr. Saleha Rizvi to please come up and take away the session now.
मैं रुक गया भाई, चला रहे हैं। इस पर हटाओ, हमको कॉपी करना है। मैं भैया पेन ड्राइव हमको कॉपी करना है, ये करना है। हाँ, ये लगाए हैं। खुला तो है, यहाँ से कटेगा तभी तो है। क्या? इसमें मॉडिफाई करने से पहले ये आपको तो नाम से एक दो तीन यही तो देखो देखो इसमें तो सही नहीं, इसमें देखो निकाल कर लगा रहा है। हमको कॉपी करना है ना, हमको कॉपी करना है वो नहीं यार। Look forward. And you have been in Netherlands, spending quite a bit of time here, and obviously started the academic career in 1999 as a researcher.
And too many kind words on me because that would be probably raising the expectation for this talk, which of course is expected to be really on time because my colleague in the room has a lecture afterwards, so I'm talking at the same time.
Yes. You please go ahead. You please go ahead.
So how can I thanks first of all for inviting me. It is a pleasure to be connected with two great countries. Of course, one is also great in size and in number of population, and India has always attracted me. So one day I will come. But now I'm literally there. And the second country, which is much smaller, is the one where you are sitting now, and that's Rotterdam. And so I spent 3 years there, and very good memories and friendship are there. Starting from Syria, where my same name, and we both drove miles around. So we kind of pretend we are smiley people.
wonderful.
So can I share my presentation?
On the bottom you will see share the screen and the green.
Okay.
Share the screen.
Okay. Now I'm trying to share the screen.
Yeah.
Okay. And then I'm showing it on my screen. Probably that's the easiest thing to do. Okay. Okay. Can probably will take a second, but you should start seeing it.
Yeah, wonderful.
Okay.
Excellent.
That was the title that has been assigned me. I will try. I had to trim it down because in 20 minutes left. We don't have much time to discuss it, but please note my email address on top in red. It was of curiosity at UNICAP, which stands for Catholic University, East Italy. And so we are a small country, but we are also a peninsula, a little bit like the Indian subcontinent. So I feel, and after all, we are all Indo-Europeans. And Sanskrit was the father of all our languages. There you go. Revolution languages as well as genes. So I see connection there. So personalized medicine means you're doing the right thing for the right people. And in order to do that, you need to have knowledge. And to make a brain function, you need thousands of genes working in a timely fashion and coordinated way. If you disrupt one of those genes, something is going wrong, maybe not dramatically, but that depends, of course, on the type and on the expression timing of that particular gene and on the type of variant code. So this is the place you're sitting now. One total healing is missing because this is an old picture. And here it's half of this building, and when I spent my 3 years, I was on the top of this building. You could almost see all of the Netherlands because it's so flat. And it's so orange even with all the light. So beautiful place, close to the sea. And let's first say that intellectual disability for me is a misnomer. I'm still considering mental retardation to be a more appropriate name. But this became out of fashion in 2010 when grassroots organizations pushed for the name change. Since retard is being used as a shame word in the US especially, and therefore intellectual disability was preferred. This is unfortunately a treadmill which is happening with many of these words because over time I'm sure that also the D word will become rude, just as the R word is now become. But the problem with intellectual disability is that basically the definition is the same. You have announced that during the developmental period. So basically you're always lagging behind. That's why I like the name retardation. Because it just means you're lagging behind. And it means you're lagging behind from the start. Okay? If God not willing, I should get a stroke tonight, then tomorrow, from tomorrow on, I would be likely disabled. But that's not the same thing as being mentally retarded. I mean, from the beginning you're behind, but you're still growing, so you're not stopping there. So actually, disability might be considered more offending, and actually innately, we tend to use now the so-called different ability or diverse ability name, just to underline the fact that we're all a little bit different, and we all have our own handicaps. So the point here that I was making is that changing the name is not so important. What is really important is social integration. That requires funding. It's not just a stroke of pen changing the name. You really need to integrate children from the start in the school system and then provide opportunities for working according to their abilities. Of course, the more you invest at the beginning, the better they will have chances to do things useful for society and for themselves. So, after all, our society should be judged by the way we care for those members that are more in need. So I love these two Dutch brothers who have Fragile syndrome because they laugh at us. They really laugh at what we still don't know about many of the genes that we can check overnight now with the powerful technology. But still we have to work all the effects of the variant of the many genes which cause intellectual disability. Now, I spent most of my academic career working on Fragile X syndrome, which is probably the prototype for mental health with intellectual disability. But it's not only that, as you will see in a moment. So the two brothers laugh at us. You see they have large ears, they have an elongated face, and they are very cheerful people, but they have a malfunctioning gene. The gene is called FMR1. It's located on the X chromosome at the X228, so on the long arm at the end. And the problem is the CGG repeat, which is in the 5' untranslated region. CGG repeat, sorry, I hear. Okay, wait. Yeah. So please, thank you. Yeah. There was someone talking, and okay. So these CGG repeats will, over time, in some families expand, and when they become above 200 repeats, this will, and that's depicted here by the black box. So these are, you should imagine these as being 200 CGG repeats, so CGG, CGG, CGG. This huge expansion will cause an epigenetic inactivation of the promoter. The C's, the cytosines, which are followed by guanines, can be methylated, and this, of course, triggers an epigenetic inactivation of the locus. And, of course, if you don't have mRNA, you cannot have the protein. So it is actually the complete lack of the protein, because the gene is on the X. So if you're a male, you only have that copy, that causes mental retardation and intellectual disability. But indeed, we know that this expansion is responsible for two conditions. Now, genes always surprise us. The gene was learned in 1991. We are still learning things about this gene. And what we know, and what we have discovered only 20 years ago, is that when you have a pre-mutation, which is the expansion comprised between 56 and 200 repeats, the gene is still on, but the RNA, which contains this partial expansion, let's call it, is actually toxic. And we still don't know whether it's the RNA per se which is toxic, or the production of some peptides that are should not be produced because the overriding frame starts from downstream of the CGG expansion. So the overriding frame is here depicted in light blue. So these are the coding exons. So we are here, the expansion is in the 5' untranslated region of the gene. But we have now discovered this very interesting phenomenon of repeat-associated non-APG-initiated translation. So when you have a repeat, this is not only for Fragile X, for many dynamic mutations, you have should not be produced because there is no AMG, there is no sarcosis. We know that probably the secondary structure formed by these repeats on the RNA will trigger non-ATG or non-ATG-initiated translation. This is very, very interesting. But what we now know is that this is a neurodegenerative condition, late onset. So older people, around 60, they will start having problems with keeping their balance. They have ataxia, they might have tremors, and eventually they will become dement in some cases. But this is completely different from the full mutation, or the complete expansion, which abolishes the synthesis of the mRNA. So there is no toxicity, but there is lack of FMRP. And that lack of FMRP, since it is highly expressed in the neurons, will cause a problem of spine immaturity. And that, of course, causes the intellectual disability. Just two slides very quickly to show you this is the active locus with the alpha-PAL and the USF1 transcription factor and the RNA polymerase complex. But when you have the expansion, which is here depicted by red, you have lots of CGGs, and these form secondary structures. And these secondary structures are recognized by the DNA methyltransferase. They are added with methyl groups. These will immediately cause one of the transcription factors to be discharged. And then the suspension of some methyl binding proteins will cause a compaction of the chromatin in this domain, and exclusion also of the second transcription factor, USF1, which is not methylation sensitive, but still it is now being excluded because the chromatin fiber is closed up. So we thought about an epigenetic therapy. We thought what would happen if we achieve DNA demethylation. If we remove this methyl group, would we turn on the gene again? And the other second epigenetic event that we have characterized is histone tail deacetylation. That is also typical of inactive heterochromatin. So we tried to do some experiments in vitro on Fragile X cell lines, and we use both 5-alpha-deoxycytidine in order to achieve passive remethylation of the DNA, and some acetyl donors in order to raise the levels of histone acetylation. Now, this actually turned on the gene again with 5-alpha-deoxycytidine. You can see these bands reappear when there is a plus, which indicates the treatment with 5-alpha-deoxycytidine. The top lane is, of course, the control messenger from HPRT, so the control gene. And also the protein reappears, although only in a subset of cells. Of course, the method is not so efficient. The problem is that we cannot use this drug in vivo, not because cells are not dividing, neuronal cells are not dividing, they are post-mitotic. And this drug achieves passive DNA demethylation, which means you need to have cells that are dividing. So I could do that in culture using lymphoblasts from patients, but I could not possibly envisage a way to use this drug in vivo. So this was a proof of principle study. Now, the gene was cloned in 1991. It's almost 30 years this May, actually, that the gene was cloned. We still don't know all the details of what is the lack of FMRP causing, because FMRP is an mRNA binding protein, and it binds hundreds of targets. So basically, the lack of FMRP will cause an upregulation of translation at the dendritic spines of many messengers. And this just shows the number of trials, of clinical trials that have been made with all these compounds indicated in red, starting from, of course, many that target the so-called metabotropic glutamate receptors, and still we don't have the golden bullet that we can use in vivo for patients. We do see some respondents, but we still don't have the perfect bullets. So the real thing that the real truth is that we still don't have a treatment for Fragile X syndrome. And of course, also genetic therapy would entail carrying a copy of the gene without the expansion into neurons, which is of course not a trivial thing to do still. Now, these two targets, ERK and mTOR, are very well known. They are at the heart of many of the secondary messenger pathways inside the cells, and the attention has shifted to those two targets now because they are more central, and probably they might have more pleiotropic effects. There is one simple drug that we could use for targeting those pathways, and it is metformin, the most commonly and widely prescribed anti-diabetic drug. Metformin has worked on mice, and our friend Ilse Gamtois, who is originally from Belgium, but worked also in the Netherlands and is now in Canada, has tried this in 2017 on mice, and it does work. There are some anecdotal reports of metformin being used in Fragile X patients who are overweight, because that is also used to control weight, and the results are interesting. Now there is a clinical trial ongoing in the U.S., which started 1 year ago, and we are trying to organize a similar study in a trial in Rome as well. So this first part is just to give credit to many of the people that have been in our lab, and to my mentor, Professor Giovanni Neri, who is here on the right. But this is just a picture of the Fragile X chromosome. You see there is really a fragile site. And this coincides with the expansion of the CGG repeats, and that causes, under certain cytogenetic culture conditions, the lack of condensation of chromatin because the CG repeat is still lagging behind and is not duplicated at the time of mitosis. And that's why you see the fragile side. And the little boy here on the top, on the bottom right, is the first patient that I've seen in my entire life. He was such a lovely boy, a little bit large ears, but for the rest, you don't notice anything. The face elongates a little bit with time, and they are generally hypotonic. That shows also why the cartilage of the ears is usually anteverted. Okay, so in 1990, no gene had been identified causing intellectual disability on the X chromosome. Now, we have over 130 genes on the X chromosome that whose mutations have been associated with intellectual disability. On these maps that you can of course request, I can send it by email. FMO1 is the one indicated by the arrow on the bottom, but all the other genes are indicated in black when their variants cause a syndrome, so a complex phenotype which includes intellectual disability but does affect other organs and systems. And the genes that are indicated in red are their mutation cause neurological phenotypes, so intellectual disability plus other problems like neuronal conductivity problems, or maybe L1-CHEM, for example, causes hydrocephalus, while the other genes which are indicated in blue, in light blue, their mutations only cause intellectual disability, also, so pure intellectual disability. So just to tell some stories, at the beginning of the 90s, in 1993, we had observed this interesting family. I love drawing pedigrees, by the way. That's my first thing we do when I interview patients, of course. We spend 1 hour with them as all medical geneticists know. It's not a trivial pursuit. It's very important. So we had 4 affected males in this family. They're all connected through females. So this clearly suggested X-linked inheritance. And these 2 shaded females also did have some impairment. Of course, that means that the second X chromosome was not compensating for the defect on the first on the affected X. And we were actually missing this individual. We could not collect DNA from this individual. In the 90s, what you could do is to extract DNA and look for markers in order to pinpoint by linkage analysis where the gene should be. And indeed, we had mapped the region, but this was a very big region, and we had lots of genes in that region. Eventually, we could get hold of the DNA of this last patient, and he was recombinant in this portion, so we did have inside the linkage interval, but that still was very big. Anyhow, we started testing one by one, sequencing one by one, the known X-linked intellectual disability genes in that region, and we were lucky enough that the second gene, which is called interleukin-1 receptor accessory protein like 1, we found a stop codon, which was co-segregating with the condition. So basically, this was done in 2006. So actually, it took us 13 years, from 1993 to 2006, to solve this family. First, things have changed a lot, and now things move faster. So 20 years later, when we had only 2 brothers, sorry for the quality of these pedigrees, hand-drawn, these 2 brothers were both intellectually disabled. They don't look alike, actually, so they don't have a particular phenotype. And we could not do any linkage study because it was just 2 patients. We didn't have enough power. But what we first did, as we now do regularly for all intellectually disabled children, we first excluded that there were either macrodeletions or macroduplications or rearrangements by array CGH. And luckily enough, we found a deletion that was exactly stripping away the first exons of the L1 RAPL1 gene. So again, the same gene, we could find this deletion, and both boys inherited this 1 megabase deletion from their mother. So there you go. We finally had found the solution in just a few months. Of course, if we have isolated cases, if you imagine that we might have an autosomal dominant intellectual disability due to a de novo missense mutation, how would you approach this? How would you solve the case. Now, we don't have, if you don't have a family, you cannot do a linkage study. And of course, you don't have internal controls. Now, we would need all the patients and families. And of course, we can do a whole exome sequencing or a whole genome sequencing, like Professor van der Peck can do. But then you need the interpretation, and you really need to segregate the family. So it's always important to go back and to the stories and see what and possibly do also some functional studies. This is why it's also important to draw not only blood but also to transform at least lymphoblastoid cell lines from the patient, or maybe do a small skin biopsy and culture and save some of the fibroblasts. So I'm actually over time now. This is a greeting from our university. It's a big university hospital. The university itself is on the back. But I'm very fond of this picture because the late John Paul II, the Saint Pope, is represented in this beautiful statue here. And he was often a guest of our university hospital when he was ill. And that really reminds us of the important mission that we have as doctors. So let me ask if I have still some time or if I have to stop here.
Yeah, take 5 more minutes if you.
Okay.
All right.
So this was another, I'll go very fast. Another family with 3 affected males. We did some linkage. As you see, they are not looking particularly similar. And but there was something in common in their brain imaging. So please always try and have at least one of the patients with a CT scan or, if possible, an NMR. And in this case, what you see is that the cerebellum is smaller and it's asymmetrically smaller. So you have a hypoplastic cerebellum. And also the uncle, in retrospect, had both both hemispheres of the cerebellum, which were smaller. Now, actually, with time, you see that there is also an enlargement of the ventricles, and there is a reduction of the thickness of the brain on top. Now, I knew of one of those many genes that was actually causing a smaller cerebellum, and this is called oligofrenin 1 or OPHN1. So this time I could go directly. I did a very quick linkage study. I had confirmation that the gene interval was linked, and then after that we sequenced the gene and found a nice splice site variant that would cause actually the activation of a cryptic splice site. In the beginning, we thought that there would be an inclusion and an in-frame inclusion of these 16 amino acids because this was in-frame. And indeed, we also have that one, but we also know that most of the other variants reported are actually loss of function variants. So it's either deletions, nonsense, or frame shift. So we reasoned a little bit more on that. And then we, although we had published that there was the insertion of the 16 amino acids, we have rerun some of the experiments. We could find that actually the mRNA variant, which was most commonly represented, actually was skipping the exon 7, which is something that very often happens when you have a splice site variant. So although we did have the longer mRNA with the inclusion of this bit of the intron with the 16 extra amino acids, the main transcript is lacking exon 7, and that is basically causing a problem in the function of the protein. Although the protein is expressed, it's altered. So one last family was actually submitted to Peter van der Peck in Rotterdam. This is also an X-linked family, apparently, and they did WES, WGS, so whole genome sequencing, and a mutation, a variant was found in this third gene, which is called ZC4H2. And in this case, the variant was a missense variant in the beginning of the protein. Now, of course, prediction programs, I only depict here Polyfen, but many of the other programs said that this missense variant was, of course, causing a problem of being pathogenic. But of course, bioinformatic predictions need a functional validation. And this was done in this paper, where, of course, Peter van der Spek's group was instrumental, otherwise we would have never found variants in the first place. But But then we joined forces with Professor Charles Schwartz, with other families, and they have done, in collaboration with Chol Kim, a zebrafish study. And then that was the definitive proof that our variant, as well as the other variants in the other families that have been identified in the US, was causing trouble. So in conclusion, always look back at your interest in patients. If you have a family, so better. Check the history and pictures with care to see if there is a particular phenotype that might join them. Sometimes there is no particular facial phenotype or gestalt which is there, but it's always wise to establish some cell lines. So try and see whether you can use EBV virus, Epstein-Barr virus to establish lymphoblasts, or prepare some skin biopsies and freeze the fibroblasts, redraw the family trees. Of course, exclude chromosomal abnormalities by array CGH. You can do a SNP array if you have the facility, but if it's a sporadic case, that won't help. And then, unless you have any clinical clue for a specific gene, like I did when I had the hypoplastic cerebellum, then you probably will resort to NGS techniques. Now, gene panels are, of course, good when you want to write a report. If you have to sign a report that excludes variants in a number of genes, then use a gene panel. But if you're looking for a new gene, you need at least whole exome, not Mendelian, not Mendelian, because that's only 4,500. You need whole exome at least, or whole genome if you have the power to analyze, and in that case, ask data from the text. Thanks for your attention, and I'll be taking questions if you have any, or otherwise, namaste.
Wonderful, excellent, excellent, excellent.
I'm glad you liked it.
Yeah, Pedro, fantastic piece of work, or rather many pieces putting together. Wonderful, wonderful. And
okay, so I will stop the sharing of the video, and we are back with all our nice pictures.
yeah, I'm really thankful for joining you at this platform, and hopefully when the pandemic is over, that we would have more chance to see each other.
Yeah, but in the meanwhile, maybe if you have interest in family, we can collaborate and try and solve it. Asking, of course, for the support of Professor Van der Stek.
Yeah, we are all together.
Okay. So I'll silence myself, I'll keep listening, okay? Grazie. My video is stopped. Please switch on my video.
It was possible that the school would be like the unity of planets and would be multiplied. In case that was true,
Please switch on my video. Organizers, please switch on my video. Organizers, please switch on my video. Yes.
So is it okay? Is it okay now?
Yeah. No. No, I can hear and see. Okay. It was a real, it was a really interesting talk, Dr. Sharma.
Yeah, it was very nice. So, Dr. Goel, would you introduce? You have the details of the next speaker, or
Dr. Sharon. Dr. Sharon?
No, Dr. Hasib.
No, I have only Sharon's CV. You can introduce me.
Okay. I'll introduce Hasib. Hasib bhai, are you there?
Is it the Hasib or the Sharon will talk first? Who will talk first?
So the time for Dr. Sharon was 3:30.
Dr. Hasib, are you there?
Yes, I'm here. Actually, unfortunately, I'm facing some problem with the internet. Hopefully, everything will be okay. Yes, I'm here.
Yeah, Hasib.
Do you want me to go first then, while he, if Hasim?
I think Sharon was the number one.
Is there any?
Dr.
Thank you.
I'm number 3.
Can she go earlier than you?
Sure, sure. Okay, no problem. With me.
No, the capacity needs to fix his internet, otherwise I'll...
Yeah, I think you can say.
Please go ahead. Go ahead.
Yes. Okay. Okay. Should we introduce Dr. Sharon?
Yeah, please go ahead.
Okay. Myself, Dr. Goyal. I got supervised from AIMS Bhopal and right now at TS Mishra Medical College. Hereby, I'm really impressed to see the CV of Dr. Sharon. She is a senior lecturer in pathology at Lambe Institute for Translational Research in Ireland, Galway, Ireland. And she is recipient of many prestigious research grants and Irish Cancer Society funding. Her remarkable research is to understand how mRNA and viral proteins derived from human endogenous retroviruses K influences tumor biology and patient's outcome. And she has studied its effect on stromal cell activation using 3D models, stromal tumor interactions for breast and prostate cancer. It's very interesting. And this was possible because of our initial understanding of the nitrosative stress, involvement of nitric oxide and INOS, etc. in breast and prostate cancer development and progression. Examining the role of herb K protein, different proteins like GAG and ENB, etc. on tumor cell phenotype and signal transduction path, a real translational research of clinical importance. So I really congratulate Dr. Sharon for wonderful research, and I will appreciate if she can start the presentation. Dr. Sharma, you have to say something?
No, that's fine. That's lovely. Please go ahead, Sharon. We are very much impressed and welcome to Lucknow, the city of Nawab, but this time online. But hopefully you would have a chance to visit this city of Nawab, we call it, but immense hospitality you will get there once you are there. Please go ahead. Please go ahead. Unmute, please.
Okay, I'm unmuted now, yeah, I realised. I'll just share again. So thank you so much for the invite to come and talk today. And so I'm really, really honoured. So let me just... Can you see that? Is that okay? Great. Okay, perfect. So thank you so much for the invite. And so I'm really, really honoured. I'm really excited by the program that you have put together there in your university, because I really do believe that personalised medicine is so important, and I think it's our future. Just background-wise, so I would have done a PhD in cancer biology and then a master's in public health. And I spent 4.5 years at the National Cancer Institute in the US training as a cancer prevention fellow. So it became so apparent to me there that we really, really need to understand what is behind individual persons' cancer susceptibility and their tumours. So today I'm going to give you a talk on human endogenous retrovirus K. So I'm going to introduce the topic to you because I know a lot of people are not familiar with it. It's part of a larger program of research that I have. So just before I start, so this is my current team, and one of the things that you'll notice is that 3 of my staff are actually from India. And so it's over the years, my lab for some reason has developed into almost like an Irish-Indian lab. And I think it really, really reflects the quality of the graduates from India, and also like quite a number of our faculty are from India as well. So we do have strong links, and we're really interested in growing these links with India and Erie University. So that just introduces you to the lab. So my main research goal is to unravel the role of inflammation in cancer progression. And so inflammation can come from various different sources. So this can be at the systemic level, so things like lifestyle influences such as obesity, exercise, etc. Also infectious diseases. We all know about things like HPV and cervical cancer, hepatitis B, and hepatocellular carcinomas. So all of these different areas really, really influence the development of cancer. Of course, then there is inflammation that occurs at the tissue level due to oncogene activation, also like aberrant immune system signaling. Let me see if I can get my mouse up pointer just so you can see. Great, yeah. So here, so all of these different things contribute to cancer, both development and progression. So in the lab, we use a combination of different methodologies. So we use molecular epidemiology. We've spent quite a large amount of time developing patient cohorts, with detailed clinical pathological features, their patient outcomes, etc. So that really does involve strong relationships with the medical, so with our medics in the hospital as well. And then we use in vitro models of tumor biology to try and understand sort of things that we see in patients. Are they just associated with the disease or are they causal? And then more recently, I'm really trying to develop multiplex molecular pathology, so things would be things like imaging cytop, etc. So I do believe that this is going to really, really open up the field for us. So as I mentioned, my interest is in inflammation in cancer. And in prostate cancer, we know that inflammation and then oxidative stress and nitrosative stress does play a major role in the initiation of cancer and in the development from pre-neoplastic lesions into adenocarcinoma and then later on into metastasis. So in this area, I am looking at the role of nitric oxide, but also the human endogenous retrovirus K and how it contributes to this for the development of prostate cancer. So just to kind of introduce you to HERV-K, the HERV-K is human endogenous retrovirus. And so before I talk about that, I just want to mention for people, what is the composition of the human genome? What's really interesting is that the Genome Project, it enlightened us and it actually told us that only 3% of the human genome actually encodes for genes, mRNA, and proteins. So, when this was discovered, we just kind of assumed that a lot of the rest of the DNA was purely just junk DNA and didn't really have any function in physiology or in disease. What's interesting is that within this, the retrotransposons, which are here, they account for approximately 45% of the human genome. So this includes things like your LINs, your SINs, and then the ERVs. So this is the endogenous retroviruses. And this just shows you a little bit of the structures of these. So now I'm interested in the ERVs, which is this one here, which is the endogenous retroviruses. And this schematic, again, just really breaks down what are the retrotransposons. But essentially, I'm interested in these ones here, which are the endogenous retroviruses. And we know that these show increased activity in some diseases. So basically, the endogenous retroviruses were introduced into our genomes during evolution, and we now inherit them. So as I said, 8% of our genome contains these viruses. The majority of the viruses would be mutated and non-functional. So, we don't have live viruses as such in our genome. But if we look at them, we can divide them into 3 different classes. So class 1 contains gamma and epsilon viruses. Class 2 is the beta retroviruses, and then class 3 is the spuma-like retroviruses. So wherever you see HERV, that's the human endogenous retrovirus version. But then also within here, that you'll see some, these would be kind of like, equivalent endogenous retroviruses that you would find in, say, different animals, etc. So a classic one, I'm interested in the HERV-K here, which is the most recent integration. And the HERV-K virus consists of a family of 10 different families called HML1 through 10. And so it's a bit of a misnomer, it's being called 1 through 10. It doesn't mean that 1 is the youngest and 10 is the oldest. 2 is actually the youngest and is the most recently integrated. And these were discovered because of their similarity to the mouse mammary tumor virus, which we know induces spontaneous breast cancer in mice. So there's a similarity here. It's about a 66% homologous. But what I just wanted to kind of point out to you is that these are not unique to humans. So the oldest HERVs would have been inserted approximately 100 to 150 million years ago. And so these would be shared by all mammals that have placentas. So they will play a role there. And then the oldest known HERV-K, so this family, the oldest known insertions would be 55 million years ago. So this would suggest that around 55 million years ago during evolution, there was this infectious retrovirus that would have been homologous to the HERV-K. And it continued to infect right up onto the most recent insertions, which are estimated to be about 500,000 years ago. It's not thought that these days that it is infectious anymore. It's thought to now just be, a fixed thing in the genome and it is inherited. But what is interesting about these is that we share a lot of these HERVs with chimpanzees, bonobos, gorillas, etc. Some of the research into archaic hominids as well, like Neanderthals, shows that we do share them with those as well. So you can nearly classify how old the insertion is based on which primates you can find them in. So this is just so as I mentioned, the HERK-HML2 is the most recent integration into the genome, and it's the one that is the most intact, and it can produce mRNA, it can produce viral particles, different proteins, etc. So this is a study by Zhu et al. In 2020 in Frontiers in Microbiology. It's very good. There's a research paper and a linked review of it, and I'd highly recommend if you're interested to visit this. And so they have done the most recent mapping of HERK throughout the genome. And what they found is that there's over 1,063 HERK-HML loci throughout the genome. And of these, 973 will be what we call solo LTRs. So I'm going to show you in a minute the structure of the HERK, but these are the LTR sequences that would be at either side of where it encodes for the different proteins. And so these won't produce proteins, but because of where they sit, if they're in proximity to genes, they can actually drive the expression of the genes because they have promoter sequences themselves. So this is thought to be a way that HERK-HML loci might actually regulate genes. But there's 90 provirus insertions, so these would encode for your proteins, your mRNA, etc. And what I just want to show you is if we zoom into a little section here, what's interesting about this is that they seem to be concentrated in areas where you actually have genes being expressed. So there does seem to be this sort of selection for the HERK integrations into areas where you have genes. So they could be either modulating gene expression via those LTRs, or if they were inserted into a gene or into the intron of a gene, they could also exert effects. But by themselves as well, by the proteins that they produce, they can have effects themselves. So this is what the structure of the HERK looks like. So the LTRs on either side, you can produce the GAG, the pro, the pol, and the envelope proteins. And then we have two different types of the HERK-HML2. So type 1 is the full length, so it produces the full length envelope. And this little accessory protein REC, which can go into the nucleus and can sit down and regulate some of the promoter regions. And then some of them are called type 1 because they have this 292 base pair deletion. This only occurs in humans, so this is a recent change in the virus during the integration. And it proteins, but instead of the REC, it produces the MP9 because of the deletion of the envelope of this region. So what is the evidence for HERK in cancer? So we see evidence for it being expressed in breast cancer, prostate cancer, colorectal, cervical, pancreatic, melanoma, lymphoma, etc. But the majority of the studies that have been done to date were either very small, like with a very small number of tumors, in the region of maybe 45 tumors, 10 controls. And also another thing would be that the majority of studies in cancer are more along the lines of association studies. They haven't really been looking into mechanism as such. This is a review that we've just recently written, and it's currently under revision at Frontiers on Oncology, so hopefully it'll be published soon. The ways that we would postulate that HERK may regulate within tumors. So the mRNA themselves, because if you can imagine if a tumor cell is overexpressing HERK, essentially it's like it has a viral infection. So it can activate toll-like receptor signaling, leading to NF-kappa B activation and then potentially correction. Likewise, the accessory proteins may regulate some of these different regulatory proteins and essentially stopping them from repressing gene transcription and allowing the upregulation of genes such as the androgen receptor or c-MYC. So, when we look at it, then we're really interested in both understanding, to what degree is it involved in cancer and what are the potential mechanisms of action. So that's the research that the lab will be doing. So in prostate cancer, what was the existing evidence for HERK in prostate cancer? So this study here by Goring et al. Looked at the expression of HERK at one of the loci, so at the 22q11, and found that there was an upregulation in the mRNA at this particular loci. And this was, I think, 11 benign controls and about 45 tumors. So they did see this upregulation at this particular loci. Then Adoni et al. Actually looked in cell lines and looked at the mRNA expression of both the LTR and the envelope protein. and saw that it was upregulated and expressed in each of the different prostate cancer cell lines. Agoni et al. Then went on the same year to look at the effects of irradiation in a variety of different cell lines, from prostate, cervical, head and neck and breast. And they found that the HERV-K was expressed in all the cell lines, but for some reason in prostate cancer, you could induce it up further with irradiation, but not so much in the other cell lines. And then more recently, then Dorian et al., same group as back here, they looked at to see what were the different loci that were being expressed. So one thing is I would mention that there's 90 different proviruses throughout the genome, and they are normally methylated in the healthy adult and potentially active in the embryo, so it's giving us hints of what the function might be. But we find that in different cancers and different tumor types, different loci are activated. So it probably requires both demethylation at the loci and then initiation of a transcription factor that will come in and initiate the transcription of the HERV-K. So going then to what do we want to look at in prostate cancer? So when I look at prostate cancer, so for those of you who are not familiar with prostate cancer, so it's a cancer that develops very gradually over time. You know, if we look at 20-year-old men, you know, some post-mortem studies have shown that actually there's signs of HERV-K developing as early in the 20s, but generally it doesn't become clinically apparent until they're in their 60s. So very, very slow. The initial diagnosis is made because of rising PSA levels. And then generally at this point, we can cure the majority of our patients through surgery and radiotherapy. But in some of them, then it's already metastasized to the bones and it lays dormant for 15 to 20 years. And then there's some sort of initiating factor that causes the HERV-K to come back up again. So my lab has three major questions in and around HERV-K and prostate cancer. So one is HERV-K predictive of prostate cancer? So previous studies, as I mentioned, have only used very, very small numbers. We're also asking, can HERV-K improve PSA-based prostate cancer testing? And what is the biological impact of HERV-K on prostate cancer? So the first study that we did was to assess the levels of HERV-K mRNA in the blood of healthy males versus prostate cancer patients. We also wanted to see if there was any differences based on ethnicity. Does it vary by pathological stage, deletion score, so these would be measures of the severity of the tumor. And then we were also interested in the influence of smoking status, more so because we had an interest on the effects of smoking on the development of metastatic disease, so it was something that we added into the study. So this is based on a cohort in the US where I would have done my postdoc back in 2006 to 2010, so I've maintained all my links with the US. And so I have access to their patient studies. So we looked at 135 healthy males and 294 males. And this just shows you just the kind of, what I kind of want to point out here, mainly the main things are that these are early stage prostate cancers. We have a combination of men of African American descent and European American descent. And this is quite important because African Americans are at greater risk of developing prostate cancer and also at greater risk of developing more aggressive forms of prostate cancer. You see similar as well around breast cancer in these different ethnic groups. So what did we find? So we measured the HERV-K levels in the blood of the men. And what we found is, so this is a logarithmic scale, so there's a significant elevation in HERV-K expression in men with prostate cancer versus healthy controls. If we then look at this, so if we do look at the odds of developing prostate cancer based on whether you have median levels in the normal population, like below or above, so basically low or high. So someone with high levels of GAG is 6 times more likely than someone with low having a diagnosis of prostate cancer. If we then actually break this into 4 different quartiles, because what we're looking for here is a dose effect. So does the greater amount of HERV-K that you have, do you have a greater risk of prostate cancer? And what you see is if you compare somebody in the lowest quartiles of HERV-K versus someone in the highest quartiles, somebody in the highest quartiles is 17 times more likely to have prostate cancer. So this really indicated to us that there is a link between HERV-K and prostate cancer and potentially may have use as a diagnostic tool. As I mentioned, African Americans have an increased risk of developing prostate cancer compared to European Americans. So when we looked at the levels at baseline in healthy controls, and what's interesting is that African Americans have a higher level of HERV-K at baseline. So we do wonder, is this HERV-K playing a role, like potentially maybe there's specific HER2 loci that might be activated in African Americans or demethylated that just renders them at a bit of an increased risk. So this is all research. So like going forward, one of the things that I would really like to do is, if obviously we had enough money, would be to look to see in a patient study like this, which loci are actually being transcribed, and is there specific loci that are associated with more aggressive disease versus less aggressive. We also did protein staining, so like as I mentioned, we measured the mRNA in blood of the patients, and then we looked at the protein levels in the patients. And what's interesting is in the patients, actually, the levels of HER2 are higher in the African Americans versus the European Americans. This is just looking at protein levels in a panel of prostate cell lines. So these three here are all prostate cancer cell lines. This is a normal prostate cell, and you can see HER2 is absent. And these are just some breast cell lines as well, just as controls, because we'd already looked at this in breast, and so we were using that as our positive control. We looked then at the staging, and what you can see is comparing stage 1 to stage 2. Stage 2 patients have higher levels of HER2 than those diagnosed at stage 1. So these would be smaller tumours, larger tumours. We don't really have enough patients at stage 3 or 4 to be able to really investigate this. We didn't see a difference with Gleason score. So Gleason score is essentially the tumour grade, and it's a measure of differentiation. So no differences there. So there's not a difference with respect to Gleason score. As I mentioned, we have the interest with smoking. So smoking is an interesting one. So smoking does not increase the risk of developing prostate cancer, but men who have prostate cancer and continue to smoke are far more likely to develop metastasis. So we've done a study around that. We published that in Cancer Research back in 2016. And so we were interested then because we knew that there was an association between HER2 metastasis and breast cancer. So do we see something here? And what's interesting is that the association between prostate cancer and the HER2 levels is actually greater in those who are current smokers. And this is looking at never versus former or current. And then if we look at the pack years, so this is almost like a dose accumulation of smoking over your lifetime. You see the greatest accumulation would be with those with the highest pack years of smoking. So that tells us that HER2 is elevated in prostate cancer. At the time then I was thinking, okay, well, could we use this as a screening tool? But the reality is that we wouldn't have the evidence to use this as a screening tool beyond PSA. So we decided, okay, let's look at the clinical questions and what's needed. So I asked, could we actually use HER2 to improve PSA-based prostate cancer testing? And so this is the current study that we have ongoing in Galway at the moment. And so just to explain the dilemma here, so classically when a man goes to his GP, he's tested for his PSA levels. If the PSA is elevated, he's more likely to have prostate cancer, so he's referred into our rapid access clinic for assessment. And it's quite an invasive procedure. It involves having a biopsy done, which is between 12 to 24 needle biopsies. So very, very invasive. But the other thing about this is that actually, of those men with elevated PSA, only 40 to 50% actually have prostate cancer. So we have designed a study to ask whether or not could the HER2 actually predict amongst those with elevated PSA who has prostate cancer. And the idea would be that if we can show this, then potentially we can reduce the number of men who will need to undergo biopsies. So one of the biggest problems with PSA is that PSA is also secreted by benign prostatic hyperplasia, and sometimes to higher levels than what you find in prostate cancer. So we got a TMA and we scored the HER2 protein on the TMA. And interestingly, what we found was that for benign prostate hyperplasia, only 20% of them are positive for HER2 versus 78% are positive within prostate adenocarcinomas. And if you looked at the PSA here, this would probably be 90% positive. So it does suggest that it's a much better biomarker. So what we're currently doing is we've now recruited 72 of our 200 patients. Unfortunately, with COVID-19, we got shut down for 6 months, so it's delayed us a little bit. But our plan is then to see whether or not HER2 can predict positive biopsy. Additionally, with our plasma, we can look at whether or not HER2 is activating viral response genes, looking at pro-inflammatory cytokines, interferons, etc. So this is all planned. This is work that Jake is doing. And so maybe in a year's time, I'll have the answers for you. So it's an ongoing study. And then finally, the other gap, so just to finish off, as I mentioned, to me one of the biggest questions though is what's the biological impact of HER2 on prostate cancer? is it just associated with cancer? Is it just associated with it? Do we just see it just naturally increasing with the development of prostate cancer, but maybe it's not really doing anything, maybe it's not really influencing the cancer progression? So to answer this, we have been developing shRNA to knock down the HERV-K out of our prostate cells. And so what we've done is, this is just first of all, this is some work that we did around before we started the knockdown. So we just wanted to confirm that HERV-K is expressed in prostate cancer cell lines. So this is a panel of prostate cancer cell lines plus the breast cell lines. And what you can see here, these are the androgen receptor positive ones, so very, very high in the androgen receptor positive and also present in the androgen receptor negative, and these are metastatic. We also looked to see what would happen if we treated the cells with androgen. When we put androgen onto the, so testosterone essentially, onto the prostate cancer cells, we get an induction of the HERV-K envelope protein. So we know that it's androgen inducible. We also look to see whether or not, so one of the things with tumors is that as they get bigger, you get the hypoxic centers, and that can turn on a whole load of very, very nasty genes that drives prostate cancer progression. So we use cobalt chloride, which is a means to turn on HIF-1 alpha, which is normally expressed under hypoxia. So this is the HIF-1 alpha. And when we do this, we see an increase in the HERV-K envelope as well. So it may be potentially HIF-1 responsive. So we also grew our tumor cells in 2D versus 3D. And so 3D is like spheroids. So essentially it's like mini tumors that we grow in the lab. And when we do this, when we grow them large enough, the center of them will become hypoxic. And indeed, when we do this, we see an increase in the HERV-K envelope, certainly in the LNCaps, not so sure about PC3s. But all of this is kind of showing the regulation of HERV-K in prostate cancer. So next time what we did was we knocked down HERV-K. So if you can see here, this is a map of the HERV-K provirus. And if we 4 different shRNA designed at different points, and because it's transcribed as one large mRNA, and then it's further processed into the individual proteins, if we use the shRNA, we should actually take out all the proteins all at once. So when we do this, this is the effects on the mRNA expression. So we reduce envelope expression with our 4 different shRNA, and we've lost almost entirely lost protein expression here as well. And so we got reduced expression of protein. And then what we did was we looked at the effects on the cell proliferation. So this is the normal proliferation in healthy, well, not healthy, in the control cancer cells. And we see reduced proliferation. So when we take HERV-K out, we reduce down proliferation capacity of the prostate cancer cells. And this is just another measurement of looking at the slope. So a reduced growth rate as such. And then this is where we have looked at the cell migration. So this is the ability of the tumor cells to migrate and squeeze their way through these little tiny 8-micron pores. So we essentially see the cells at the top, we have gradient at the bottom, and they have to undergo epithelial mesenchymal transition and squeeze their way through the pores. And then we measure how many cells make their way through. And essentially knocking out HERV-K really reduces migratory capacity. And in breast cancer, we've shown it also reduces the invasion through various different matrix cells and extracellular matrix proteins. And so it really does suggest to us that HERV-K is not just associated with prostate cancer, but actually can be responsible for some of the aggressive nature of prostate cancer. So not only could it be used as a way to detect prostate cancer, but potentially we have a way to look and see, how aggressive is somebody's tumor, and also potentially therapeutic targets. So in summary, HERV-K predicts prostate cancer diagnosis. We're currently exploring its utility in men with elevated PSA. Does it predict positive biopsy? We know that the HERV-K knockdown represses prostate cancer cell proliferation, invasion, and migration. And we're now currently exploring the molecular mechanisms. So what genes and what signal transduction pathways, etc., does it regulate? And we're also overexpressing the individual proteins, so like the envelope protein, the GAG protein, the REC, the NP9, to see what the individual proteins belonging to HERV-K can do to a cancer cell and how they're regulated. And so this is where we're based. This is the Lab Institute for Translational Research. We're on the hospital grounds. The university is literally across the road. We have clinical research facility on the bottom, so we have all our patients. And then we have our 2 labs here. So it allows us to really do the translational studies. This is my current lab. These are my past PhD students and postdocs, all my various different collaborators. and then all my different funders. So thanks so much for listening, and I hope that was of interest to you all.
Excellent talk, madam. Wonderful work. And may I ask you very quick two questions?
Yeah.
One is whether you try to look it in the circulation, like serum or, and the other thing is whether any microRNAs also you may look around. And
So,
the last is, can you knock down any protein and then see the effect of curing it? Is the question.
Okay, so first question, did we look in the serum? So we looked in the PDMC fraction, that's where we measured the HER-K. So we need to figure out whether it's coming from circulating tumor cells or whether it's actually, it could also be that the immune cells are actually expressing HER-K. So we know the tumor does as well, that's an area that we're going to look at. We do know that in the serum that you will actually find antibodies against it. We have not checked to see whether the mRNA can be isolated out of plasma or serum, but that's certainly something we can do. Then you asked if knockdown of individual proteins would affect functions. When we first started this, we were designing our siRNA thinking we could knock down HER-K, but because we transcribed as a single mRNA, when you knock down, you get everything. So instead, what we're doing is overexpress
Please switch off. Please, and please mute your laptop.
I have a question, Sharon, to you. Exactly the same one which the former the chairperson has asked you. Where is the location of this retrovirus? Whether they are found in testes, and what is that that during metastasis that that exaggerate this virus? It might be some ORF or something. Have you correlated it any time?
Sorry, so where's the location of it?
Yes,
In the
of
tumor?
this virus. Yeah.
In the tumor?
Normal individual.
Okay, so in normal, it's not thought to be in the testes beyond the embryo. So we do know that it's involved in embryogenesis. We know that you can see it in embryonic stem cells. You can see it in pluripotent stem cells. But it's thought that then it's silenced in the adult. So a lot of studies in normal tissues, maybe there might be some evidence in testes, but it's more in testicular cancer it's ramped up. So it's some of the studies have said that you don't see it in the healthy normal adults. Now, I don't fully believe that, because when we were developing our immunohistochemistry, we did see it in tonsils. We saw it in some of the lymph nodes. So I think like it can be found in other parts of the body. It's also activated in autoimmune disease. So that can make it quite difficult to try and figure, because people have different comorbidities.
So what was the reason to choose MSc? You chose MSc for PCA.
Oh, MSc because we do stromal cell biology, and what we were hoping was, we wanted to see was the MSc negative. It's more kind of a negative control, but also because we wanted to see whether or not, one of the things that we're really interested in is can the tumor cells transfer the HER-K to the MSCs. So before we start that, we needed to confirm that the MSCs are negative. Because HER-K can be packaged in messenger RNA, can be packaged into the exosomes, and then potentially transferred over. So that's a way that the tumor may potentially spread the HER-K in a non-infectious way.
Excellent.
Yeah.
I think coming to the Dr. Goel point, it would be good if you will check the knockdown of some HIF one protein or related protein, because you have seen it with cobalt chloride that this virus is getting impacted with HIF1. What do you think?
So you're asking if we knock down HIF1?
Yes, exactly.
I think that's a really good idea. We also because we know that it stands, we can also induce it downstream of the TLRs. I know I mentioned that the TLRs can activate it, but we see a whole regulatory system. We also have, where we have increased INOS, we have increased HER-K. When we repress INOS, we get reduced HER-K. When we repress the estrogen receptor in ER positive, we can reduce it. So there's obviously distinct regulation within the tumour, so hormones definitely regulate it. Like I said, the area is so underexplored that we've probably got 100 things that we want to do at one time to answer the question. So it's, but I think you're definitely right. I think we should knock down the HIF1 alpha or use, yeah, because obviously there's so many different things that we could do.
Anyway, wonderful talk.
Thank you very much.
Thank you very much.
Thanks a lot. Dr. Sharma, if you say something?
Yeah, there is one short query from Ghazala Zedi. Is she there? She wanted to ask some question, Ghazala.
I think we have few time restrictions, so I would request the chairperson.
Yeah, she raised her hand, so I wanted to give her the chance, but if she's not there, it's fine.
Email me.
I think we should move on to the next speaker. Thanks a lot, Dr. Sharma.
To chat here, anybody who wants to can contact me after.
Yeah, we will contact you on your email. It's a wonderful idea.
Thank you very much.
Ma'am. Yeah.
That was a wonderful talk. I would like to quickly move to the next speaker, which is, who is waiting and he has to go to, I think his wife needs to go to the hospital, so he's also very fresh at the time. Dr. Hasib, are you there?
Yes, I'm here and I postponed her appointment.
Oh, wonderful. Okay, then you are a little bit at peace. All right.
Yes. So there's no time restriction with me.
All right, please go ahead. Hasib, I'll just say a few words about you. You hail from the alma mater where I graduated, called Aligarh Muslim University. You did I think the entire education from AMU, bachelor, master, and PhD.
No, not really. Actually, I did only PhD from AMU.
Oh, not bachelor?
No, I did from Rohilkhand University.
Yeah, so PhD from AMU, and then you have been in different parts of the world, traveled, trained, even in Denmark and US. You have had multiple, the exciting thing is that you combine your biological sciences research in using the modern technology, so developing even the programming language, and I think you were awarded one of the prestigious prize by the Microsoft some years ago, and you are based right now at the King Saud University, heading the department there, and I think it would be lovely to hear your talk. We are going on with the timing, constraints. So I think we can manage within this time frame. So please go ahead, Hasib. I'm very pleased to have you. Welcome to this new platform, the personalized medicine, and we look forward for more association with you in the future. Please go ahead.
Thank you very much, Professor Sharma, and my sincere thanks to organizers as well of this virtual conference for giving me the opportunity to interact with the scientific community. This presentation is about biomarkers of glycemic control. So I should give some basic information about these biomarkers and also discuss about the findings of some of my research papers which were published in the same field. So in this slide, I have included both the biomarkers of hyperglycemia as well as the biomarkers for glycemic control. There are two main biomarkers for glycemic control. They are very famous, HbA1c and serum fructosamine. For hyperglycemia or glycemia, or even for hyperglycemia, we use fasting blood glucose, random blood glucose, and the gold standard is OGTT test. There are few more biomarkers for hyperglycemia. They are like continuous monitoring of blood glucose using a probe that is implanted, or in some hospitals they use like hourly monitoring of blood glucose. But mostly they are used for determining the hypoglycemic events. So now I'm going to discuss these two markers in this presentation. First, we must understand the glycation of proteins, because those markers they are based on the glycation of proteins. Glucose molecules they combine with the proteins in the bloodstream, and that process is called glycation. These proteins, as we know, this is the albumin is most abundant in blood, or there is another very abundant protein, is hemoglobin, which is inside RBC. So glucose will interact with both these proteins and some other proteins as well, which are present in blood serum. And the formation of the glycated proteins is proportional to the level of glucose present in the blood. And that's why the reason these glycated proteins are used as a biomarker of hyperglycemia or cumulative glycemic load. These combined molecules persist as long, so their persistence in the blood will depend on the half-life of RBC or other proteins. First, I'm going to talk about HbA1c, also called glycosylated hemoglobin, or in short, HbA1c. This is a normal physiological process, the formation of HbA1c. However, the average, so when the plasma glucose level increases, so in proportionally, HbA1c will also increase. And this will give the cumulative load of blood glucose for the past 2 to 3 months, which is the half-life of RBC. And this test has been recommended as a standard biomarker for testing as well as monitoring diabetes, especially in type 2 diabetes. Here we can see in this figure, the process is like this is the RBC. Inside is hemoglobin, and glucose enters RBC and it binds permanently. This binding is actually permanent, covalent binding, and this is the formation of glycohemoglobin or HbA1c. This slide is for those who want to know HbA1c comes from where, especially for students. So we know the hemoglobin, HB is the short form for that, is about 96% of the RBC dry content. So this is abundant in RBC. And normal adult hemoglobin consists of HbA, HbA2, and HbF. This is depending on these subunits, alpha, beta, or in HbA2 there is delta or gamma. And then the composition is, you see here, HbA is abundant, is 97%. And about 5% of the total HbA is called HbA1. So it comes from where? If you do a process of this segment of hemoglobin, HbA, we will see many bands. So these terms, HbA1, HbA1A1, HbA1A2, HbA1B, these are the different bands on chromatography or electrophoresis. And HbA1c of these bands, actually, this is utilized as a biomarker for glycemic control. And the 5% is the normal value. This is in each individual, it's about 5 to 6% is glycated HbA1c. If you see the historical background, so starting in 1958, it was first isolated by Huisman and co-workers. In 68, it was characterized as glycoprotein. In 69, by Raval and co-workers, they found elevated HbA1c in diabetic patients. Then its pathway was discovered in 1975, 76. It was proposed as a biomarker for monitoring blood glucose levels. The formation of HbA1c takes place in this pattern. This is hemoglobin, this is glucose, and the intermediate is called Schiff's base, and it binds with the N terminal of the beta chain of hemoglobin after alveolar rearrangement. So this is the stable molecule of HbA1c. This is the information about the units of HbA1c. So there are two units, both are commonly used. The first one is percent. This is DCCT, Diabetes Control and Complication Trial Unit. And in Europe, actually mostly they use millimoles per mole. So one should not confuse with millimole, which is blood glucose actually. We use the term millimole. So this is millimole per mole. So this is the bound part and this is the unbound part. In here also, this is 6% and 6% bound. The remaining is unbound. There is a conversion formula also. If you want to convert this IFCC to DCCT, we can use this formula. We can use the opposite as well. This chart actually tells about already the converted values. This is blood glucose millimole per liter, milligram per deciliter. And here are HbA1c. These are the corresponding HbA1c values for determining the status. So up to 6.5 is actually normal. Then comes pre-diabetes, and these are the grades of diabetes. This is, I think, this is a repetition, but here is the reference range. So the normal is 4 to 5.6, then pre-diabetes more than 5.6 to 6.4, and above this is cutoff value is recommended for diagnosing diabetes. There are many tests for analyzing HbA1c. Mostly HbA1c is commonly used. Then there's immunoassays can also be used, diabetic method and capillary electrophoresis. There's affinity chromatography also. The only difference between these two is the difference of column. There is a close relationship between glycemic control, or we can say blood glucose, and cardiovascular disease. This information I have got from the literature. I'm summarizing here. The major cause of reduction in life expectancy in diabetic patients is associated with cardiovascular complications. They are closely associated. The role of hyperglycemia is usually supported by direct correlation between this FBG, fasting blood glucose, and cardiovascular events. Elevated HbA1c has been suggested as independent risk factor for CVD and stroke in subjects, both diabetic as well as non-diabetic subjects. So HbA1c or glycemic control is directly correlated with cardiovascular disease as well as stroke. Even attempts to reduce cardiovascular risk resulted in improvement of HbA1c. In one study, they mentioned like this, and if we target this in reducing cardiovascular risk factors, automatically HbA1c levels goes down. So based on these points, we can say that there is a complex interaction between carbohydrate and lipid metabolism. So we study the impact of glycemic control on lipid profile of diabetic patients. And some of the data actually I'm presenting here. If anybody is interested, you can just go through this, the difference I've mentioned here, the details. So there's a direct correlation between fasting blood glucose and HbA1c. Here we can see the diagnostic potential of HbA1c. These data I think are from about 16,000 patients. And this is the ROC curve. No, this is not the ROC curve, this is the histogram actually. And this is the cutoff. What we use 6.5. We use 6.5. So these in the left side, if we see, so they are actually false negative if we use HbA1c as a criteria. So this 3.7% of total patients is 3.7% false negative using HbA1c, 6.5% cutoff criteria. And if we use this diagnostic criteria for HbA1c using fasting blood glucose cutoff, then the cutoff level is 7. Then we get 3.7% false positive values. So using the same data, we created the ROC curve here. And based on this ROC curve, HbA1c, we got this area under curve 1, that means 100% sensitive. Means all the individuals can be diagnosed using this this criterion of HbA1c 6.5%. And if we use fasting blood glucose, then the curve goes down. In this case, this is the green one is HbA1c, and this sensitivity, this is actually true positive, and this is false positive. One minus specificity. This is false positive. Here the curve goes down because of that 3.7% false positive values. This is about dual biomarker potential of HbA1c. So we correlated HbA1c values with the lipid profile, and we found that HbA1c is not only useful biomarker for long-term glycemic control, but also it is a good predictor of lipid profile. You can see from these two, I did not give here the total cholesterol because actually there was no significant difference. So this is the x-axis, these are HbA1c values up to 6, this is the normal value. Then more than 6 to 9%, the unit is percent, or more than 9%. So we can see the direct correlation with the triglycerides. And here we can see the inverse correlation with HDL. More details can be found here. This is my own paper. So these data were used by a Japanese pharmaceutical company in their product brochure. These are the same plots from our study. These are the advantages of HbA1c test. Provide assessment of chronic hyperglycemia and glycemic control. No fasting is necessary. Variation is very less. Single test can be used for both diagnosis as well as monitoring. Directly related to complications of diabetes, that means it can predict the complications as well for prognosis of diabetes. There are certain limitations as well. So low HbA1c levels are associated with chronic renal diseases, hemoglobinopathies like sickle cell or any other kind of anemia. So because that is based on RBC count. High HbA1c levels are associated with iron deficiency especially. However, mild anemia, it doesn't significantly affect HbA1c levels. This information I got from literature. HbA1c also, they are difficult to interpret in context of gestational diabetes mellitus, because this is a temporary kind of diabetes, and there are fluctuations also in the levels. Again, this is the negative point. HbA1c integrates glycemia over the lifespan of RBC. That means for the last 2 to 3 months. So if we want to test the effect of any drug, we cannot use this as a biomarker. And if we want to, for example, if we want to get the results within a week, we cannot use this as a biomarker. So we have to use fasting blood glucose as a biomarker. This is the second biomarker, serum fructosamine. So as we have seen in the I think the beginning slide, so glucose, it binds with all types of proteins. So there are many proteins which are outside RBC. So this serum fructosamine is actually a corrective term of all those. Here we can see here that glucose binding with the hemoglobin inside RBC, and this is serum part, mostly albumin, maybe some IgG, or some apolipoproteins. So those all these segments, they are called together fructosamine. And the formation is like this. This is the protein, this, and here the glucose molecule. There's intermediate first. This is glucosylamine. Again, there's a rearrangement here. You see that this is C1O bond. Here this is CH, and this is double bond is here. So this is fructosamine, and this is stable molecule. This is our study. I've given here the reference. So we found that here, you see, this is corrected fructosamine. Actually, there's an equation how to do this, how to get corrected fructosamine. This is corrected with the levels of either albumin levels or total protein levels. There is this formula, very simple formula. So we can find corrected fructosamine levels. We found direct correlation with both fasting blood glucose as well as random blood glucose. These are the correlation coefficients. This slide is about paired values of fructosamine and either fasting or random blood glucose. Both these biomarkers, fasting glucose or random glucose alone, they are not regarded as efficient screening test for GDM, the gestational diabetes mellitus. This is based on previous reports. So if we lower down the threshold of FBG to 4.4, it will not miss any case of GDM. There will be 100% sensitivity. However, but very low sensitivity with high false positive in this case, we are lowering down the cutoff. We are diagnosing all, but there are 55% false positive. They are most important. False negative are less important, but false positive are very important. We have to avoid false positive results. This assay is associated with poor sensitivity and specificity for diagnostic purpose. However, use of paired values of fructosamine and either of these markers would be very sensitive and safe strategy to filter high-risk patients for conducting. So we have to filter out. For example, if there are like 1,000 patients, so if we apply this strategy, we can filter out from 1,000 to 50 or maybe 100. These are our data, and I have given reference here. I'm sorry, it's not, the visibility is not very good here in this. But the strategy is like this. There are total 165 subjects. So we apply first criteria of fasting blood glucose more than 5.3. Just this is no. If no, we apply another criteria. So the strategy is like this. This is the first marker. Then we apply second marker. This is fructosamine. No, this is more than 2.5. No, that means it's normal. If yes, it's coming here. So we are filtering from this to this. So we are reducing the number of these patients on whom we can perform OGTT. The same strategy is here, but here in this case, we use fasting blood glucose. Here we use random blood glucose in combination with fructosamine. We conducted another study. Another study on multiple visits of patients. So I will take only just five more minutes. So in this study, we recruited 51 pregnant women, and we collected 211 blood samples from the 51 patients at different time intervals. So our samples were like this. There were 3 samples from 22 patients, 4 from 16, and so on. The gap between this sampling was 6 to 30 days. We used 2 cutoff values to classify hyperglycemia, and we use for fructosamine, we use this is the reference range for fructosamine. So using the lower cutoff, 19 subjects were classified as hyperglycemic. This frequency was further reduced when we use this cutoff. Combined values filtered 6 high-risk subjects with prediction of gestational diabetes mellitus. We use this cutoff for all these markers. More details can be found here. I have given the reference down. The most important point is this: the fluctuation in these 2 markers were not similar. There were more fluctuations in fasting blood glucose. You see the coefficient of variation, 13.27, whereas in fructosamine it was much lesser, 5.49%. Another important point was this: they were not correlated. Means fluctuations in those patients in case of this. In this case, we found fluctuations in other patients. So they were not correlated to each other. And you can see here the correlation coefficient 0.007. So that means if we combine these 2, so they will get different patients, not the same patients. Same information you can see here very easily. These are all patients here. And here in the y-axis, this is coefficient of variation. This is not the marker value, but the variation. We can see here, for example, in the patient number 25, there's more variation in fasting blood glucose, but there's less variation in fructosamine. In this case, you can see here in number 11, this is opposite. Here is also opposite. So that means they are not dependent on each other. Number on the top, these are the number of samples from the same individuals. And this is the reference. You can find more information from this reference. So together, the conclusions are HbA1c is not only useful biomarker for long-term glycemic control, but also it is a good predictor of lipid profile. That means it has dual biomarker capability. Monitoring of glycemic control using HbA1c could have additional benefits of identifying diabetic patients who are at greater risk of cardiovascular complication. So it will do 2 jobs, HbA1c. Another important point is the time course fluctuation FBG, fasting blood glucose, and fructosamine in pregnant women. They are independent of one another. That means we can use the combined values of these 2 markers. They will be more advantageous to filter out high-risk patients on whom OGT, this is actually the gold standard, on whom we can perform OGT. This time taking test OGTT, sometimes it goes for 2-3 hours. And I would like to acknowledge those scientists. I use some images on slide number 4, 8, 9, and 19. So I want to give credit to all those scientists. Here is one announcement. I have one special issue open. This is the title is this special. This is special collection. This is not the title. Starts from here. Inflammatory mediator in COVID-19 and other diseases as well. So if anybody is interested, you can submit the paper. The last date is 31st August. And thank you very much for patiently listening to this talk. Actually, this was more student-oriented presentation.
Thank you, Hasib. It was indeed very nice. And also, as you said, for the students, and actually that is the key for the future. And all the audience which is sitting online and offline, some of them are in the lecture hall. They are, I'm sure, they are benefited with such a lovely presentation. Thank you.
Thank you. Thank you very much.
Yeah, please. Dr. Goel, is there some other talk now in this session? I think we are done for this session, right?
So shall I cancel the sharing?
Yeah, that you could do, but maybe there are some questions from the audience, or
Yes, the session is now open for any queries or questions from the audience. Shadab sir, please.
This was a wonderful talk, though I missed some part of it initially. So, with conclusion, what I can get is that HbA1c, you said, is the correlate for both the glycemia as well as lipid profile. So, am I right?
Yes.
Yes. So, like, how do you really differentiate in a patient that this is a good correlate for either if a patient is suffering from a lipid disease or a glycemic disease, then how you, or if he has or she has both of them, then how do you really differentiate it? This marker,
this is quite possible. Actually, it happens. Oh, they are mostly in most of the cases, they are together. They occur together in most of the cases. You see, most of the diabetic patients, they later, if they don't control the blood glucose level, so later they develop cardiovascular problems. So they are correlated. So most of the patients actually they are having. You see, the patients above like 50 or 60. So the occurrence is mostly together.
So which come first?
Mostly actually the culprit is blood glucose. Is the culprit. So there will be advanced glycation products, and they cause inflammation also in the body. When they are stored, they cause inflammation. And the another problem is, if you see the glycation of proteins, when the proteins are glycated, so their own physiological job is altered. So they don't function properly. Sometimes they are cross-linking between the proteins. Sometimes they bind with the receptors as well. So if the ligand is there, but the receptors are blocked. So the whole process is very, very complicated. And you see the glucose and lipid metabolism, they are also interrelated. So there are so many questions which are still unanswered.
You mean a lot of things has to be done. Okay, thank you very much.
So with this, we come to the end of this beautiful session on genomics. I would like to thank our esteemed chairperson.
Yes, Doctor, I have a question from your right, please, if possible.
Yes, sir, please.
Yeah. Good evening, everyone. Professor Khan, I have a question for you.
Yes, please go ahead, Dr. Basim.
So, if the raised HbA1c level has only been seen in patients with acquired rise in lipid profile, or even in familial and genetic conditions related with a deranged lipid profile?
No, in my opinion, actually, all the patients in which I worked, actually, there were several thousands of patients. So what I did, I didn't go in the genetic analysis. Because I'm talking about the patients which we use. So we simply, and after publishing this work, there are many other studies also. They found the same. They found the same conclusions. It is correlated. So if there is some genetic causes or not, we did not study it. So this we can find in literature.
Right.
So instead of yes, I don't want to give some wrong answer.
Right, right. So probably that could be another place where we can look for answers.
Or we can do some study. As I said before, there are so many. This is still, when I see the literature, they still mention. We don't know this. What is the mechanism of this?
Right. Thank you so
For
much.
example,
for
in
the
yes,
insightful talk.
thank you.
Thank you, sir.
Thank you so
Excuse
much,
me,
sir.
sir.
Yes, sir.
This is Dr. Basim from Iraq. May I have a question, please?
Yes, sir, sure.
Okay, thank you much. This is Dr. Basim from Iraq, professor of clinical pharmacology and consultant physician. Okay. Okay, thank you, Dr. Hassi, for this nice topic and nice presentation. Actually, I have two questions, please.
Yeah, go ahead.
Yeah. Okay. The first question is, in addition to the list of factors that affecting the results of hemoglobin A1C, for example, the hemoglobinopathies, chronic renal disease, and so on and so on, my question is whether the sampling procedures could affect the result of A1C. For example, this process of sterilization, the syringe type, the tube type, and so on and so on. Because we, in the practice, we notice that a lot of variations among the lab results for the same patient at the same time. This is the first question. The second question is, for those with hemoglobinopathies, I mean, for the sickle cell anemia or any iron deficiency anemia, is there any adjusted cutoff point for those patients? I mean, other than the standard cutoff point or the fixed cutoff point? Okay, thank you.
Yes, just to answer to your first question.
Yeah.
What I feel regarding the collection of blood samples.
Yeah.
So what I feel is very important to store the samples properly. Is after collection. So we have to store the sample before analysis. If the samples are not being analyzed at the same time, so it must be stored properly. This is one that may affect the levels. Because there's no necessity of, like, for example, for blood glucose, so we have a special tube for that. We have to collect that fluoride. There's a special gray tube to avoid any glycolysis.
Yeah.
But in this case, I think we have to take care about the sample storage, and the use of standard curve must be proper, and the technique depends also on the technique also. Notifier, if we use SPLC, the other person will be using enzyme, ELISA, or some other technique, or affinity chromatography. The affinity certainly will be more accurate. It's on boronate column, so that has high affinity for HbA1c. So it will give best results. So variation is there. Your second question was about the enemy.
The cutoff point.
Any correction?
Yeah.
The correction I have seen in fructosamine actually.
Oh, yeah.
If you see the literature, so I think almost all the papers on fructosamine, they use corrected fructosamine.
Yeah.
So, but
not for A1C.
Yeah. Even for myself also, is every 3 months.
Yeah.
I get my this HbA1c tested here in the hospital. So this is simply give HbA1c value in percent, not the corrected.
Okay, thank you very much. Thank you very much.
Thank you very much.
If there is no more questions, shall we go ahead with the next part?
Yes, sir. I would like to thank our esteemed
Are there some more
chairperson.
questions?
I think it's all.
If that is not the case, take the moderator at the chair.
Okay, sir. So now we would like to begin the third and the last session of this evening, which is on the topic of global concern, that is cardiovascular disorders. Since CBD now is not considered as a disorder or a disease of elderly, but it is rapidly spreading its roots
You are
in a young
muted.
adults, in a
You are
young adults
muted.
as well.
VC office.
Okay.
You are muted.
Sorry, sir. Am I audible now?
Yeah, just now, yes.
Thank you so much, sir.
Yeah, you are okay.
Okay, thank you, sir. So we would now like to begin the third and the last session of this evening, which is on a topic of global concern, that is cardiovascular disorders. Since CVD now is not considered as a disease of elderly, but is rapidly spreading its roots in our young adults as well. So without further delay, I would now request Dr. Rajshekharan Surappan, Associate Professor, Division of Molecular and Cellular Pathology, University of Alabama, Birmingham, USA, to kindly take over the session as moderator. Sir?
Thank you. Thank you for the nice introduction. And I've been watching the program. It's really great. Good morning, good evening, good afternoon to everyone. And it's my great pleasure and honor to be the moderator for this wonderful session organized by the conference organizers, which is Personalized Medicine in Cardiovascular Disease. And before getting into the session, I would like to introduce our chairpersons, Professor Dr. Jalil Fatima from IRA University, Lucknow, India, and Professor Dr. M.U. Rabbani, Aligarh Muslim University, Aligarh, India. Particularly, I would like to invite them to introduce the speakers of this session. The first speaker is going to be Dr. Elisabeth Deindl from Munich, Germany, and the next speaker, Dr. Fazal Karim from IRA University, and the third speaker is myself from University of Alabama, and the final speaker for this session is Dr. Federica Del Monte from Medical University of South Carolina, USA. So with this short introduction, and this is going to be a great session, I believe, and I can see that there are a lot of attendees eagerly waiting. So without further ado, I would request Dr. Jalil Fatima and Dr. M.U. Rabbani to introduce the speaker. Thank you.
Good afternoon, everybody. I'm Professor Rabbani from Aligarh Muslim University. Thank you, Dr. Rajshekharan, for your kind words. So I'm going to introduce the first speaker of this session, Dr. Elisabeth Deindl, and she is from Munich, Germany. She has done extensive research in arteriogenesis, vascular biology, innate immunity, and extracellular nucleic acids. She investigates the molecular mechanisms of arteriogenesis. It's the growth of pre-existing arteriolar connections into fundamental bypass. For these studies, she employs a murine hind limb model. In detail, she is studying how the trigger of arteriogenesis is translated into biological signals and how these signals are propagated within a cell as well as from cell to cell. Moreover, she is investigating the functional role of innate immune system. Besides a variety of molecular and immunohistology analysis she performs in vitro. Presently, she is a scientist at Ludwig Maxi University of Munich, Walter Brendel Center of Experimental Medicine. And she will be speaking on impact of cold-inducible RNA binding proteins on ischemic tissue damage and vascularization. So I invite the esteemed speaker, Dr. Elisabeth Deindl, for her presentation.
Dr. Rabbani, thank you very much for this kind introduction. And I also want to thank, of course, Hari Sharma for the invitation again. So giving me the chance to show our really latest results here. We have submitted them a few weeks ago, and today we received the revision, and I think we will publish it within 1 week. So very, very brand new results on cold-inducible RNA binding protein, and this time not on arteriogenesis, but on angiogenesis. And I think I should, or I try to share my screen. And yeah, let's start. So, wait a minute. Hope that this is the right. Can you see my screen now?
Yes.
Ma'am.
Yes, perfect.
Perfect. Okay, then here. So, can you also see my cursor?
Yes.
Yes.
You can see.
Okay, fine. So the title is Impact of Cold-Inducible RNA Binding Protein, shortly called SIRP, on ischemic tissue damage and vascularization. And I think it's a quite interesting topic. So, vascular occlusive disease. I think every one of you knows vascular occlusive disease like peripheral artery disease or stroke or myocardial infarction. Here I have just a short scheme on peripheral artery disease. So what happens? All the time an artery gets occluded. If an artery gets occluded during PAVK, myocardial infarction or stroke, the distal tissue, of course, gets ischemic, associated with ischemic damage and also associated with an extensive infiltration of leukocytes and, of course, capillary formation, also called angiogenesis, mainly function. So who's working? Maybe the guy who's working can switch off his micro.
Yeah, please.
Guys, please switch off the mic. This gentleman with the RKS. Who is RKSZ? Switch off the mic.
Ma'am, you are muted, ma'am. Dr. Elizabeth, ma'am, you are muted.
So now, I think someone muted everyone, so I was not able to speak. But now I think you can hear me again, yeah? Okay, so if an artery is occluded, this of course results in ischemic tissue damage distally with leukocyte infiltration and capillary sprouting or angiogenesis. Now, angiogenesis has mainly the function to remove cell debris and is also important for tissue repair. There are two mechanisms of angiogenesis. The one is sprouting angiogenesis, which involves the proliferation of endothelial cells, so to create a new capillary. And the other one is known as intussusceptive angiogenesis, which is just a splitting of pre-existing capillaries. So, coming to SIRP, why were we interested in this cold-inducible RNA binding protein? Now, SIRP is a stress-responsive protein, and it is activated by mild hypothermia and hypoxia. So all the tissue which gets ischemic due to vascular occlusive diseases should somehow react with SIRP expression, SIRP activation. And what is the function of SIRP? So after activation, there is an intracellular SIRP, which is translocated from the nucleus to the cytoplasm. And in the cytoplasm, it binds RNA and regulates the processing, the translation, and the turnover. And it regulates the translation, for genes which are important in apoptosis, in cell proliferation, metabolic. So many different mRNAs are bound by this SIRP, by this intracellular SIRP. So it's a chaperone. Then we also have this extracellular SIRP, which is also released due to hypoxia. And this extracellular SIRP acts as DAMP, as dangerous associated molecular pattern, and it aggravates inflammation. So of course, we were interested whether SIRP has an influence on angiogenesis and tissue repair, due to the mentioned points. Now, to investigate that, we use our well-known more or less well known murine hind limb model. What we do, we ligate the femoral artery as shown here in the right leg, and the left we do a sham operation. And this ligation of the femoral artery, of course, results in collateral artery growth in the upper leg, but in parallel, we have ischemia and ischemic damage on the lower leg, and here we find angiogenesis. So we thought this is a perfect model to investigate the impact of SERP on angiogenesis and tissue repair. So we used this hind limb ischemia model and investigated SERP knockout mice versus wild-type control mice. So we isolated here the muscle and did several investigations. And the first thing we analyzed was tissue damage. And since it is described that SERP is expressed and activated under conditions of mild hypothermia and hypoxia, we thought SERP might be important for tissue repair. And we expected reduced ischemic damage in the SERP knockout mice, but the opposite was the case. So the SERP knockout mice show a significant reduced tissue damage compared to wild-type mice, compared to wild-type control mice. Here you can very nicely see in the control mice the damaged tissue with this centralized nuclei, and we do not find these things in this SERP knockout mice. Reduced tissue damage should be associated with reduced angiogenesis. So we expected that we have in this SERP knockout mouse probably reduced angiogenesis because there is not too much tissue or cell debris which needs to be removed. So now we looked for angiogenesis, and to do so we did several stainings. First of all, we did a CD31 staining in white, in control and SERP knockout mice, in the gastrocnemius muscle. CD31 is a marker for endothelial cells. However, also some parasites are expressing CD31, and to exclude parasites from our counting, we also did a staining for ACTA2 in green. So cells which are positive for CD31 in white and ACTA2 in green are parasites. Cells which are only white, so positive for CD31, are endothelial cells and capillaries. Moreover, we did a VRU staining in red to see how many of these endothelial cells are proliferating. And the results were again astonishing, because when we counted all those endothelial cells, so defined as CD31 positive and ACTA2 negative cells, we found increased numbers of endothelial cells, so increased the capillary to muscle fiber ratio in SERP knockout mice. And moreover, investigating VRU positive cells, VRU positive endothelial cells, we found that even more endothelial cells were proliferating. The next thing we looked at was leukocyte accumulation. Therefore, we did a staining for CD45. CD45 is a pan-leukocyte marker. And as you can see very nicely here in control versus the SERP knockout mice, and here's the diagram, the chart in SERP knockout mice, we find reduced inflammatory cells or reduced leukocytes in our tissue samples. We again went more into detail and looked for individual leukocytes. And first of all, we stained for neutrophils. And here we used MPO, myeloperoxidase, as marker. All the cells in red are neutrophils. Moreover, we did a staining for citrulline H3, which is a marker for NETs, so for the DNA, which is released from neutrophils due to net formation. And of course, DAPI is a string of nuclei. And as you can see very nicely here in the control mice, we have huge numbers of neutrophils which are infiltrating or which are in the ischemic tissue. However, reduced numbers in this knockout mice in the ischemic tissue. And here's the quantification, significantly reduced neutrophils, MPO positive cells in knockout mice. Moreover, when we counted this MPO cyclorin H3 positive cells here, we found that SERP deficiency is also associated with reduced net formation. And we also calculated the number of net positive MPOs to see whether SERP deficiency has directly an influence on net formation or whether we only have reduced numbers of nets because we have reduced numbers of neutrophils. But indeed, we found that SERP deficiency has an influence on net formation. It negatively affects net formation. So in the knockout mice, we have reduced numbers of neutrophils which form nets. Then, as next, we analyzed macrophage accumulation in ischemic tissue. For macrophage marker, we used CD68. And when you compare control mice with SERP deficient mice, you see that the number of CD68 positive cells is around the same. Here's the quantification. So no significant difference, saying that a SERP deficiency influences the recruitment or the accumulation of neutrophils, but not of macrophages. But this was not all we have done. We even went more into detail and looked for the polarization of those macrophages. And as polarization marker, we used MRC1. In the literature, it's described that M1 polarized macrophages, which are inflammatory, are negative for MRC1, whereas M2 polarized macrophages are positive for MRC1 and they function in tissue regeneration and repair. They are very important. And it was very interesting to see that in our SERP deficient mice, we have reduced numbers of these MRC1 negative cells, so reduced numbers of inflammatory macrophages, but increased numbers of regenerative M2 polarized macrophages. So more macrophages which work on tissue repair and regeneration of tissue. To get an impression about the influence of SERP on macrophage polarization markers, we did also some in vitro studies. So we treated macrophages, so this J774 8.1 macrophages, which is a macrophage cell line, with SERP, and found that SERP induces the expression of M1 markers like TNF-alpha, IL-6, and arginase 2, but does not induce the expression of M2 markers like YM1 and MRC1, which very nicely fits to our data on the knockout mice. So coming already to the summary. So SERP deficiency or absence of SERP results in reduced tissue damage. As I said in the beginning, reduced tissue damage, reduced tissue damage should be associated with reduced angiogenesis. However, we find increased numbers of capillaries. We found reduced numbers of leukocytes, so mainly of neutrophils. Also reduced net formation. The number of macrophages was not changed, but, and this is very important, I think, we found reduced numbers of inflammatory macrophages and increased numbers of regenerative macrophages. So from our study, we conclude that the absence of SERP promotes angiogenesis and hence regeneration of ischemic tissue, in particular by supporting the polarization of macrophages towards regenerative M2-like macrophages. And I also have some future perspectives. In the beginning, I said SERP exists as an intracellular form, so this is I-SERP, and as extracellular form, E-SERP, E for extracellular. And the next thing we will do is to look whether the observed findings were due to the absence of intracellular SERP or extracellular SERP or both. So we can treat our wild-type mice with antibodies which result in depletion of extracellular SERP. This is the one thing. And of course, we are also interested what's going on in patients. And therefore, it would be interesting to investigate the level of SERP, intracellular or extracellular, in samples, in tissue samples of patients with vascular-occlusive disease. And then one could, of course, individually treat them if they have high levels of SERP with either minor-stranded mRNA, blocking SERP, if it's intracellular, or just with antibodies to block extracellular SERP. And this should be associated with reduced ischemic tissue damage. So with this, I want to come to an end. This study was mainly done in my lab by Matthias Kübler and also by Sebastian Beck, in part by Manuel Lasch. Helen Ishikawa supported, Ishikawa Ankerhol supported us with all the stainings. Sylvia Fischer from Gießen, from the University of Gießen, it's a PCR results or PCR analysis. And with this, I want to thank you very much for your attention. And again, Harry, thanks for the invitation. The paper is open for discussion, Dr. Rabani.
Thank you, Dr. Elizabeth, for a wonderful lecture. And you have excellently detailed about this angiogenesis and its damage and role of SERP and ISERP. And now this is open for any queries or comments from the offline online audience.
So, Dr. Daniel, this is Raj from EAB, and that was a great story. And in fact, it matches with the cardiovascular. You are studying the endothelial cells and the vessels and stuff like that. So that's great. So my question is to do with how do you compare this with the heat shock stress in relation to your particular factor, that's CIR?
With heat shock, so currently I think there are no data available concerning heat shock. It's well described in the literature that this SERP is activated by hypothermia and hypoxia. Yeah, sorry, we did some in vitro analysis and did not apply hypothermia but hyperthermia, so increased temperature. And again, we found that SERP is activated. So I think also SERP is originally described as cold-inducible RNA protein. It's a stress-inducible protein.
Okay.
And this makes it even more important.
That's right. Yeah. Thank you. That's a very good study.
Thank you.
That's the key. Excellent. Excellent talk, as usual, Elizabeth.
Thank you, Harry.
Yeah, we are all sitting online. You are sitting in Munich, I'm in Rotterdam, and people in US, and Dr. Rabbani, my kind of year mate, right? I think we were perhaps the classmates during 74, 75.
Yes, sure.
At
Nice to see you, Dr. Hari.
Yeah, and amazing, that we are all sitting in different corners of the world and presenting the work. But I just want I was
Nevertheless, it works.
One reminder, you see this photo?
Yeah.
The golden temple, just 2.5 years ago. Unfortunately, we are not there in India, but once pandemic is over, would be delighted to have you all gathered at one place. So
Maybe
Dr.
next year we have a chance, huh?
I have a comment to make that a few years back, this angiogenesis was considered one of the treatment for patients who are having coronary disease and diffuse coronary disease. But somehow didn't pick up much. And now I think that with your research and this advancement and knowing these at the molecular level, these things may come up again. And in those patients who are having diffuse coronary disease who are not draftable or not stentable. So thank you very much, Dr. Elizabeth, for
Yeah. Maybe I show you one more picture. I think you can still see my.
Yes, I can. Yes, I recall.
Yeah. So we ligate the femoral artery, and as I mentioned in the introduction, in the upper leg we found collateral artery growth.
Yes.
And we have some data which are not published, but we are working on the mechanism showing that ZERP deficiency not only promotes angiogenesis and tissue repair, but also arteriogenesis, so natural bypass growth, which is even more important than for patients.
Yeah, that's what we want in the heart. The same thing in the Hindu we want in the heart.
Yeah.
Nice to see.
So I think it's very nice or very important data.
Yes, sure.
And it should be easy in patients. If it's this extracellular syrup, one could easily block it with an antibody or antibody treatment of patients.
Yes.
Yeah.
Okay.
Are there some more questions? Please. Dr. Shashi, Dr. Rajshekharan, can you take?
Yes, sir. Now I think I would invite the next speaker. I think Dr. Rabbani is going to introduce the next speaker.
Thanks to our Honorable VC Ma'am and Organizing Committee.
And Dr. Jalis will be introducing Dr.
Okay. Yes. Okay, Dr. Jalis.
Then I'll be introducing.
Thank you so much. I thank our Honorable VC Ma'am and the Organizing Committee of the ISPMCON 2021, distinguished faculty from India and abroad, delegates and friends. With utmost pleasure, I am delighted to introduce Dr. Fazal Karim, my colleague who is working as consultant cardiology, and he's also heading the cardiology unit, which is an active division of my own Department of Medicine at Era University, working since 2015. He's a graduate from AMU Aligarh and trained in medicine and cardiology from PGI Chandigarh. He's a brilliant cardiologist. His team has established state-of-art cardiac sciences center in Era University. In a very short span of time, the center has been providing all intervention cardiology services and cardiac surgery services also at affordable prices with excellent outcomes. His active interests include complex interventions, heart failure, and critical cardiac illness. The cardiology department at Era Medical College is actively involved in research also in collaboration with the other departments. He will deliver his talk on the topic of precision medicine in heart failure, refining and redefining the perspectives. So precision medicine, as we know, it is an integrative approach to cardiovascular disease prevention and treatment that considers an individual's genetics, lifestyle, and exposures as determinants of their health and disease phenotypes. The mystic field of epigenomics, more mystic for me as a clinician, because we are we are naive to this subject. So it deals with epigenomics, transcriptomics, proteomics, and focuses to overcome the limitation of reductionism in the medicine. The reductionism where we presume that all the patients with the same signs of disease share a common pathophenotype and should be treated similarly. But this is actually not so. And as for example, with this dreaded disease about which my colleague is going to speak, the heart failure, we know that a subset of heart failure, that is heart failure with preserved ejection fraction, on which we have a lecture also in this session, represents 50% of all heart failures.
But to date, there is no therapy capable of reducing the morbidity and mortality effectively. So, building the argument more in favor of personalized and precision medicine for better outcome in this deadly disease. So, let us hear to his talk. Dr. Fazal Karim, please.
Heresy in the very near future. Precision medicine has been transforming the field of medicine, and today I will be discussing how this emerging field has refined and redefined heart failure. So, can I have the slides?
Perfect.
So, heart failure is one of the very important diseases, and the prevalence of heart failure is increasing tremendously. So much so that by 2030, 3 to 4% of the population of the world will be suffering from heart failure. Hence, there is a need to understand this disease and what are the factors which make it unique, and how we can make this, how we can be better able to treat this disease. So, what is very important is to understand that the environmental factors, genetic variations, and variable pathophysiology, all these are they contribute to the approach to the heart failure, and hence, because of this wide variation in the phenotype and the response to treatment of these patients, an omics approach is needed. So, in this flow diagram, I am summarizing how genomics, proteomics, metabolomics, fluxomics, ionomics, microbiomics, glycomics, and I think there are too many omics, and I hope that we don't land with a syncope with this, and how deep phenotyping. And then combining deep phenotyping with this multi-omics and with the use of machine learning and newer advanced statistical approaches, how we can unravel the novel networks and novel pathways of heart failure and use this knowledge for the prediction of health and disease. This provides an overview of the precision approach, and the point I want to emphasize is that we are now moving from omics to multi-omics. What is multi-omics? Multi-omics provides a greater understanding of the flow of information from the original cause of the disease, that is the genetic contribution, the environmental contribution, the developmental factors, to the functional consequences for the relevant interactions. So we see that there is a complex interaction between genomics, transcriptomics, the proteome, and the metabolome. And with this, when it is combined with deep phenotyping and subjected to network analysis, these are the new concepts which are coming, and it is directly related to artificial intelligence. We are able to unravel novel heart failure disease pathways, heart failure phenotyping, newer biomarkers for the diagnosis and prediction of the prognosis of heart failure, and newer therapeutic targets for heart failure. Cardiomyopathies, basically they belong to two broad categories clinically. Some are familial cardiomyopathies and some are idiopathic dilated cardiomyopathies. The familial cardiomyopathies, they have Mendelian inheritance as established by genetic linkage analysis, and with availability of whole exome and genome sequences, we can identify the causative mutations, and with the help of microarray technology, we can have the copy number of the variant genes. While the idiopathic dilated cardiomyopathies, they result from cumulative effect of multiple variants in multiple genes. And overall, the heritability component is 18%, and especially the single nucleotide variants have been found to be associated with the non-familial dilated cardiomyopathy. With this diagram, we will define the basic premise for precision medicine in cardiomyopathy. So the first question that it helps us to answer is who to treat. So with the application of the precision medicine technology, we are able to quantify the environmental risk and genetic risk and identify the high risk individuals. The second question is when to treat. And here comes the role of deep phenotyping, which involves imaging, which involves biomarkers. With the help of deep phenotyping, we can actually identify the subgroup of patients, the patients who have a normal heart. In these patients who have a normal heart, but they have the subclinical phenotype, we have to institute the preventive measures. And then in the patients who we detect the disease at an earlier stage, we will institute again the treatment. And in the patients who have got overt DCM, we will have to institute and optimize the treatment of symptoms. And the third question is how to treat. So again, genotype, the modifiers, and the phenotypes, these all affect our treatment approach. And we are going to discuss this in the further talk. So basic damage starts from the level of the DNA. There are alterations in the DNA, and as this is consequently followed by alterations in RNA and change in the proteins. And so these building blocks, they affect the tissues and finally the organs. So what we need to identify, what are the pathogenic and likely pathogenic genes. And the American College of Medical Genetics pathogenicity scoring matrix helps us to classify and identify these genes, and this guides the further action. Advances in clinical genetic testing has now led to the development of concept of a cardiovascular genetic clinic, which comprises of a cardiologist, a clinical geneticist, and a genetic counselor. Why do we need to do a genetic testing? This is important. See, if you look at the past 2 decades, then heart failure patients, they usually used to present in late stages of the disease. And they were associated with very poor outcomes, with 1-year mortality of 50% and further 10% attrition every year. So at the end, by the end of a decade, most of the patients would not be alive. So that is why, with the help of genetic testing, we hope to have an early detection. Early detection will lead to improved survival. Then we need to do reproductive counseling. And we very well know that these cardiomyopathies, they are medically actionable. And these interventions are going to improve survival. So clinical genetic testing consists of establishing the genetic etiology of the proband and affected family members. So we have a patient who has come to us with heart failure. This is the proband, and we strongly suspect a genetic basis for this presentation. So we will subject this patient to genetic analysis. Once we have identified the proband, then we will do a clinical evaluation of at-risk family members. And then once the gene once the gene has been identified, so once we have identified the gene uh, which is having pathological significance, then we subject the rest of the family members to cascade genetic testing and followed by genetic counseling. So with this approach, we are able to provide a deeper insight into the age of onset of that cardiomyopathy, the penetrance, pleiotropic effects, and disease expression. So genetic cardiomyopathy, they have an overlap of phenotype and overlap of genes. And these are the different morphological types, that is hypertrophic, dilated, restrictive, endomyocardial fibrosis, and arrhythmogenic RV cardiomyopathy. This Venn diagram, it shows the overlap of those genes which are involved in the development of these cardiomyopathies. So in hypertrophic cardiomyopathy, it overlaps, some genes overlap with the genes of dilated cardiomyopathy, and there is overlap with restrictive cardiomyopathy. However, arrhythmogenic RV cardiomyopathy, it is mostly because of desmosomal proteins and it does not show overlap. This Venn diagram is very important, and what it represents now the clinical availability of genetic panels. And how this was possible? This is possible because of availability of next generation sequencing, which is an advanced DNA technology. And this is the Mayo Clinic panels for hypertrophic cardiomyopathy, ARVD, DCM, Noonan syndrome, and then you have a comprehensive cardiomyopathy multi-gene panel. So, I will summarize the approach to clinical genetic testing. That first step is deep phenotyping. Deep phenotyping involves taking a detailed history of heart failure symptoms, presence of syncope and arrhythmias, and thromboembolism, a detailed physical examination including the cardiac and the neuromuscular system, imaging, ECG, echo, and MRI. And MRI is one of the important modalities now in all cardiovascular diseases. It helps us to actually diagnose what we cannot diagnose by echocardiogram. And MRI is going to become the gold standard imaging in cardiovascular disorders. I will just illustrate this diagram. This is a diagram representing the deep phenotyping of heart failure with preserved EF, which is going to be discussed in a subsequent talk. But this will show that it is a myriad of things which have to be assessed. So at the level of the organ, at the level of the heart, we have to look for presence of LA enlargement, LA dysfunction, presence of left ventricular hypertrophy, presence of microvascular dysfunction. Then in the other organ systems, heart failure with preserved EF, it is not just a disorder of heart. It is a disorder involving other organ systems. So you have to look for obstructive airway disease. You have to look for pulmonary vascular dysfunction, renal dysfunction, aortic stiffness, peripheral vascular dysfunction, skeletal muscle dysfunction. So many organs are involved, and all these lead to different phenotypes. This is the purpose of deep phenotyping. And at the tissue level, you have endothelial dysfunction, abnormal calcium handling, titin dysfunction, and myocardial fibrosis and mitochondrial dysfunction. So again, heart failure with preserved EF, there are a lot of registries. And why this deep phenotyping became important was because we were facing a lot of difficulty in treating the patients with heart failure with preserved EF. And there was not one size fit all, there was no one size fit all approach as we have for reduced EF, heart failure with reduced EF. So when this clinical genetic testing was applied, then the yield was highest in arrhythmogenic right ventricular cardiomyopathy, which was around 50%, followed by hypertrophic cardiomyopathy, followed by familial DCM. So I'll quickly summarize the steps. The step one is proband genetic testing, where the index case is identified and a panel of genes are sequenced. And if a positive variant is identified, then the rest of the family is subjected to cascade genetic testing, and the gene positive carriers are now subjected to more closer surveillance and reproductive counseling, while gene negative carriers can be released from the clinical screening. So, and as an example, we will just very briefly discuss how it is applied to DCM. So, if the patient has a known DCM-related genetic variant in a family member, then we will initiate the appropriate genetic counseling and treatment. And in the patients who are not having a DCM-related genetic variant in a family member, but they have positive family history, especially we have to take a 3-generation history, then in such patients, again, we'll subject them to genetic testing. And it has come into routine practice. After genetic testing, we are able to identify the pathogenic or likely pathogenic variants. And these are clinically actionable, and we have to institute the treatment and long-term monitoring of these patients. Another important subtype of cardiomyopathy is the hypertrophic cardiomyopathy. And in this, there are a lot of phenocopies. So it is not just the classic hypertrophic cardiomyopathy. There are other diseases like Fabry's disease, Jarron's disease, Noonan syndrome, and transthyretin amyloidosis. So these are specific. They present with hypertrophic profile, but they have different genes which cause these disorders, and they have got their specific phenotypes. We now want to discuss about the very important genes which are involved in heart failure, and the first and foremost is titin. Titin is a 38,000 amino acid multimodular protein, and it spans half the length of the sarcomere and has important spring function, providing passive force. It regulates the sarcomere contraction and signaling. So truncating variants of this titin gene, they are responsible for 20 to 25% of familial DCM, and they are also involved in peripartum cardiomyopathy. So what happens, what is the result of these truncating variants? There is decrease in the titin protein levels. There is altered myocardial substrate utilization. So what we are seeing is a complex interplay between genomics, proteomics, metabolomics. This is an illustrative example that it is not just one thing that leads to another thing. It's a complex interplay. There is activation of the mammalian target of rapamycin complex pathways. So these patients who have got titin mutations, even if they do not have overt disease, they are at risk. And any stress or pregnancy or exposure to toxins and alcohol can precipitate cardiomyopathy, overt cardiomyopathy in these patients. The second gene is RNA binding motif protein 20. It is a RNA binding protein which is highly expressed in human myocardium, and it regulates the alternative splicing of titin, calcium calomodulin dependent kinase delta 2, and other genes which are associated with sarcomere biology. Variants in the RNA binding motif protein 20 are associated again with both idiopathic and dilated DCM. Interesting point is that these are the patients who suffer from increased episodes of ventricular arrhythmias. So they have a more severe phenotype, and the proposed mechanisms are abnormal calcium handling, increased intracellular calcium in the sarcoplasmic reticulum, and increased calcium release from the sarcoplasmic reticulum. The third gene is BCL2 associated anthanogene, that is BAG3. Mutations in BAG3 are also seen in familial and idiopathic DCM. These proteins are co-chaperones that interact with ATPase domain of the heat shock protein 70, and this is induced by stressful stimuli. So this is what is epigenomics all about. How external factors they affect and how they bring about changes in the disease. So they are important in maintaining protein homeostasis, mitochondrial integrity, myofibrillar function within the cardiomyocyte. So disruption of the normal actually leads to proteotoxicity. So there is mitochondrial fragmentation and apoptosis and development of cardiomyopathy. The fourth protein is the very important group of protein lamin A and C, which are intermediate filament proteins in the nucleus. The mutations for lamin A, they account for 8% of DCM, and they are also seen, lamin A mutations are also seen in patients with HCM and arrhythmogenic right ventricular cardiomyopathy. These lamins, they are the structural nuclear filaments providing nuclear stability, chromatin organization, gene expression, and DNA damage repair. So the mutations, they lead to cardiac fibrosis, abnormal responses to mechanical stresses, defective electrical signaling, impaired autophagy, abnormal gene expression. So these are pleiotropic effects. So because they are very important proteins organizing the whole nuclear structure, their effects have pleiotropic effects. There is upregulation of the MAP kinase and the mammalian target of rapamycin complex signaling pathways. So this is a diagram of a cell which is showing the intracellular location of the various genes which are involved in the development of cardiomyopathies. And all that we have been discussing, it is not just in the realm of the lab. This is what I want to emphasize. My important message I want to give is that now this is being used in the real life patients, and as we can see, this European Society of Cardiology EORP cardiomyopathy registry, in this they conducted a study and did a genetic testing of the patients, and what were the interesting findings were that the index patients with genetic testing, they were younger at the age of diagnosis. So this was one problem that previously we were identifying the patients at a later stage. But with the institution of genetic testing and genetic counseling, we are able to identify the patients at a younger stage. They had more familial disease, there were more history of sudden cardiac death. They were the patients who received more ICDs, that is implanted cardioverter defibrillators, and the yield of pathological disease causing variant was 41.7%. This is a big number. Almost 40% patients were having pathological genetic variants. The next we move on to the pharmacogenomics of heart failure, and this diagram shows the major pathways which are dysregulated in heart failure, which includes increased sympathetic nervous system activity and activation of the renin, angiotensin, aldosterone system, and the various targets, the various enzymes, and the various receptors which are the therapeutic targets, which the drugs which are included are beta blockers, angiotensin receptor blockers, ACE inhibitors, and mineralocorticoid receptor antagonists. So there are no significant pharmacogenomics for angiotensin receptor blocker, loop diuretics, and spironolactone. However, for ACE inhibitors, the deletion variation of the ACE gene, that is the ACE-D allele, it confers the heart failure patients a higher risk of cardiovascular events, and higher than standard doses of ACE inhibitors will mitigate this risk. So, again, knowing the genetic status of the patient in whom we are prescribing these medicines becomes important. Then the second class of drugs are beta blockers, which act on the beta adrenergic receptors, and these beta adrenergic receptors have shown high degree of polymorphism. The pharmacogenomics of carvedilol, metoprolol, bisoprolol, and bucentolol have been most widely studied in heart failure. And only the first three agents, that is carvedilol, metoprolol, and bisoprolol, they have been clearly demonstrated to improve mortality and morbidity. And the basis for this is that they are the ones which induce reverse remodeling. These three drugs, they induce reverse remodeling. So this is the beta-1 receptor structure, and there are two important polymorphisms: the arginine 389 glycine and serine 49 glycine. These polymorphisms have clinical significance. This ADR beta-1 gene codes for the receptor, and it mediates the inotropic and chronotropic response, and it is involved in cardiac remodeling, and it has got pro-arrhythmic effects. So the 389. Okay. So this arginine 389 variant, these variants are associated with better response to the drug therapy. So I will just briefly overview some more important concepts. The concept of epigenomics. What is epigenomics? These are processes that relate to changes in gene expression, which are unrelated to changes in DNA sequence, and they involve DNA methylation, histone modification, and non-coding RNAs. So since we are short of time, we are not going into their details. Then the next important omic technology is proteomics, and especially the biomarkers, the proteome are the things which help to guide therapy, help in establishing the diagnosis and disease severity. And this is the overview of the biomarkers, and each biomarker represents some pathophysiological pathway. So we have biomarkers of inflammation, biomarkers of myocardial stress, ECM remodeling, oxidative stress, myocyte damage, and neurohormonal activation. Then another field is microbiomics. 2 more minutes and I'll conclude. So there is an alteration in the gut microbiome, and there are 3 important mediators. These are TMAO, secondary bile acids, and short-chain fatty acids. So there is an alteration of these products of gut microbiota which lead to disease progression. And the final frontier of this field is gene therapy. So we have been actually, there are clinical trials with SERCA2A gene, the adenylyl cyclase 6, the S100A and inhibitor 1. These, there have been trials, but the results so far have been neutral. So with this slide, I will summarize my talk. That precision medicine, it consists of 2 simultaneous processes. One is deep phenotyping, that is the role where there is the role of the clinician, and genomics or multi-omics, where there is the role of the geneticist. And combining the 2 data from the 2 approaches, we are able to actually simplify the things. So this last diagram, it shows how we are using complexities to make things simple. So very complex technologies are being used, and the purpose is to make the things more simple and to improve the outcomes. Thank you so much.
Thank you, Dr. Fazal for this elaborate account of heart failure, redefining and by the precision medicine. And as we are running short of time, so we will not take up any questions on this topic.
Thank you, ma'am.
Over to Dr. Rajshekhar.
Let me congratulate Dr. Fazal Karim on his complete and exhaustive
Thank you, Dr. Karim. That was an awesome overview of the current field of personalized medicine. Now, I may request Dr. Rabbani. Of course, he's going to do this. Thank you.
It's my pleasure to introduce Dr. Rajshekhar Namakkal Surapan, and Dr. Namakkal Surapan. Am I audible now? Okay. It's my pleasure to introduce Dr. Rajshekhar Namakkal Surapan. Dr. Namakkal Surapan has spent the last decade and a half exploring the condition of redox signaling in heart failure and skeletal muscle. Completing his undergraduate, postgraduate, and PhD thesis in biochemistry from the University of Madras in Tamil Nadu, Chennai, India, he went on to undertake his postdoctoral training in the Indian Institute of Technology, Madras, Department of Chemistry, as Department of Biotechnology, to investigate the role of nutraceutical phenolic antioxidants in diabetic humans. He continued his postdoctoral training in the Department of Medicine, Division of Cardiovascular Medicine, at the University of Utah, Salt Lake City. He studied introducts regulation of cardiac hypertrophy and heart failure. He was then promoted as junior faculty in the University of Utah in 2008 to pursue his independent research on developing unique reductive stress models utilizing the beginning grant in aid award from the American Heart Association. Dr. Namakkal was then promoted as research assistant professor in 2007 and secured funding from National Institute of Aging to study the NRF2 signaling in cardiac aging, as well as National Institute of Health to study the reductive stress of proteotoxic cardiac disease. In 2014, he joined the faculty at the University of Alabama at Birmingham in the Division of Molecular and Cell Pathology as an assistant professor, and then was promoted to associate professor in 2019. With this training and experience, he has expanded his research through use of transgenic and reductive stress mouse models to identify molecular and genetic mechanisms of pathological cardiac remodeling and heart failure. His outside interests is a family person and socializing, conducting social awareness rallies on the impact of exercise in cardiac health and writing in screenplays for Tamil movies. And so he will be speaking on reduced stress in cardiac patients and need for personalized therapy. So I invite our esteemed speaker, Dr. Rajasekharan, for this presentation. You please unmute yourself.
Thank you, Dr. Rabani. That was a wonderful introduction. Like, if my mother do that, the same thing would I expect. Very innovative thing. So let me jump onto the topic for today's interest. That is going to be the something unique, I believe, because which is something discussing about the reductive stress, which I'm going to explain in a few minutes. So before I get to my topic, I would like to thank Dr. Karim and Dr. Elizabeth for their wonderful lectures, and which made my introduction very easy. And particularly, Dr. Karim has explained everything about the HFF and the genetic influences and pre-screening for the patients and the prevalence of this disease. So it needs, of course, a unique approach and particularly a personalized approach. And therefore, this conference is very perfectly important in timing. And I appreciate all the organizers, Dr. Harishama, Dr. Rabani, Dr. Fatima, and my friend and colleague, Dr. Rishvi, for this organizing this wonderful session. So today, I'm going to talk about, we all know that the cardiovascular disease is growing. Even though there is the mortality rate of cardiovascular disease is decreased, we are spending more dollars. Why? Because we are managing it in various forms, including the left ventricular assist devices. So these are the reasons how we are able to prevent death, but still the occurrence of the cardiac disease is not somewhat like reduced or stopped. So therefore, it needs more basic research, I believe. And importantly to note that the age of the cardiac events are pretty much reduced from 65 and above to 40 and 45. So that's a big challenge to all of us. So as you can see in the slide, all these individuals, young athletes, they faint and fall on the ground, and they died. And the diagnosis was their cardiac issues. And as Dr. Karim has mentioned very clearly that there are several genes, several mutations. About 40% of the human population is carrying those mutations or genes. But depending on the epigenetic, depending on their nutritional behaviors, these genes are either expressed or are underexpressed. So we believe that the reason for these individuals is it too much of exercise, you think? We all know that exercise is beneficial, but how much of it is beneficial? So how much of the exercise could do a epigenetic regulation, whereby you can activate the genes? So these are wonderful questions to be answered. So in line with this, we wanted to ask if the remodeling of the cardiac tissue in any form beyond the physiological adaptation could be a problem. That's the major question that we wanted to. So this was the first discovery, and I would call this as a novel discovery because this was a first study which was connected to the human cardiac myopathy. Basically, the human alpha bicrystalline mutation was recapitulated in a mouse model, and this mouse model mimics the condition of the original finding in humans, which was in the French pedigree. This particular mutation is causing a human disease, which is cardiac hypertrophy, eccentric hypertrophy. But at that time, they did not know whether this was what sort of. Pardon me. Amit, please. Dr. Amit. Dr. Amit Srivastava, could you meet?
Number.
So, we believe that understanding the mechanisms or basics of the these particular disease caused by mutation was important. So, what we discovered was there was a condition called reductive in this mouse model of human disease. So, basically, redox spectrum, we all know that biochemically it is measured with the glutathione and other redox couple. And more importantly, I would like to draw your attention to this schematic overview of the redox. One could look at the redox mostly on the left side of this spectrum, which is mostly oxidative and hyperoxidative settings. But we never look at the other side. This was one of the problems, I believe, in the field, which is lacking knowledge actually in the past 6 or 7 decades. So what you see here is that hyperreductive condition is possible through either genetic activation of antioxidant genes, or it could be possible through too much of antioxidant supplementation. So if you take too much of supplements, then one could develop, in the chronically, they could develop a hyperreductive condition. So while the normal setting where you see the sort of reductive environment in cells and organs, and the pro-oxidative setting, all these three categories would be physiological signaling response, and this also could be an adaptive signaling response in response to any toxic insults or any sort of comorbidities that occur in acute or versus chronically. But when it goes beyond these stages of oxidative to hyperoxidative or reductive to hyperreductive, both could be an issue. But interestingly, when you think about oxidative, there is a natural defense, of course. Our system is able to induce the antioxidant genes, particularly that at the transcriptional priming of antioxidant genes is possible to suppress the oxidative conditions. However, we do not know what happens when you have too much of reduction in your cells or body or the given organ. So therefore, we believe that understanding the hyperreductive stress is very, very important to see if explain the sort of disorders that we could not see any mechanisms thus far. So with that, I would like to draw your attention how to define a reductive stress condition. So it is again, it's in embryonic state. It's in embryonic state, and the definition could be measuring the redox couples such as glutathione, NADPH, cysteine, or thyroidoxin reduced and oxidized forms. And if the levels of these couples is 2 or higher fold when compared to the respective controls, then that could be regarded as reductive stress. Again, there could be additional redox species or reduction and reductants and oxidants that could be included in this definition. But as of now, this is what the criteria that we use to define reductive stress. So any condition has more than 2-fold of these redox couples when compared to the respective control would be the regarded as reductive stress. So so can you hear me now? Hello? Oh, okay, thank you. So, okay, my talk is going to be have like two parts, part one and part two. In part one, I'm going to discuss about this model of reductive stress that was discovered in a humanized mouse model, and a little bit of mechanisms how this can happen. And in part two, I'm going to explain, or I'm going to show you some data how this reductive stress is connected to the human, particularly the human cardiac patients. So let us talk about the mutant chaperone induces pathological remodeling of the heart. So as you could see that the alpha-bicursilin is normally is a good protein, which is the key which is key for the maintenance of cytoskeletal architecture in the cardiac myocytes, and which is a small molecular weight protein, and particularly the amount of this protein expressed in hearts is huge. The total amount of the protein is about 3% out of the total content in the cardiac myocytes, which is huge. And main role is to prevent myocardial infarction or any given stress situations. The alpha-bicursilin is expressed and it protects the cytoskeletal architecture of the thing. And as I said, this was detected, this particular mutation called arginine converted into glycine at the 120 amino acid position 120, and that's called R120G CREAB. And this was detected in French pedigree. And what happens to these patients? So when arginine is converted into glycine, and this is what you see. So the normal heart with all four chambers intact with the septum, and you can see that this reductive stress, we believe that this is driven by reductive stress to see like eccentric cardiac hypertrophy, wherein you see the septum is hugely increased and the posterior wall of the left ventricle as well as the reduced chamber size of the left ventricle. So this is what we see in these patients, and our original study, we wanted to recapitulate this model in mouse by using the human gene and generating a transgenic mouse. So we were successful in that, and then we studied this basics of biochemistry as well as the pathophysiology. And what you see here is the transgenic mouse model of human disease, that is a human R120G at the age of 3 months. This mouse expressing alpha-bicursilin using the aminoblasts of cytosol and nucleus, wherein you can see that nucleus is more aggregated sort of proteins because this alpha-bicursilin, mutant alpha-bicursilin aggregates itself, which is called oligomerization of alpha-bicursilin, and then that is mainly accumulating in the nucleus as well as the cytoplasm. So whatever you see in cytoplasm is soluble, whereas in the nuclear pellets, basically these are perinuclear areas, which is actually insoluble aggregate. So the same thing happens at the age of 6 months. But one thing that you could notice that at the age of 3 months there is a trend in increase in the cardiac size, but at this age we didn't see any detectable physiological dysfunction. For example, there is no significant changes in the echocardiography. Whereas at the age of 6 months, you can see that heart becomes like huge, and we see that it is about 2.5 fold higher than the controls, and still you see the expression of these proteins as you saw in the 3 months. So meaning that as I could recollect the human settings, this disease, even though this mutation is present since the embryo formation, that does not does not manifest the disease until the humans reaches about like 45 years of age. So then we thought that this could be an age associated. And when we talk about age association, this is always about oxidative stress, because we all know that over the aging, the antioxidant production is declined. So normally one could think that this could be an oxidative stress driven disease. That's what we also believe. But what we got was completely different, because as you see in here, there is a transition occurring at the age of after 4 or 5 months, we see this. Within a couple of weeks, you see these mice develop cardiac hypertrophy severely with significant decline in the function in terms of echocardiography analysis. So what do we see in this? Do we see oxidative stress? The very single first parameter that we looked at is the glutathione measurements in these cars. As you could see that at the age of 3 months, you see there is a trend in increase in glutathione levels, which we did expect. We thought that glutathione levels goes down. and but which is insignificant, non-significant at this time, at this age. However, when we looked at the same mice at the age of 6 months, one could see that there is a 2.5-fold higher in levels of GSS, which is truly amazing because we never thought that this GSS is going to be increasing. So we thought, we were confused. And is it oxidative stress? No, it's not oxidative stress. Then it is clear that there is something going on. And very importantly, while all transgenic mice died of heart failure, but at the age of between 50 to 60 weeks, and we did not know whether this was caused by reductive stress. We named this condition as reductive stress because it's twofold higher GSS levels. Not only GSS levels, other parameters, as I said before, the antioxidant transcriptional system and antioxidant proteins and antioxidant enzyme activities. So at all levels, we published in this paper also that this disease was associated with reductive stress at that time. So we moved on and looked at the microarrays because it's also important to look at whether the transcriptomic profiling is altered. Because do you remember I said before that for every response, stress response, the antioxidants can be primed if that is an oxidative setting. So we wanted to analyze that, and then we did an in-house array, and we also verified with the different ways, Affymetrix arrays and RNA northern blots, and also qPCR analysis. And what we got is, this is the result. So what you see here is the two different groups, that is, two different age points. One is 3 months and 6 months. At 3 months, you don't see the disease, and 6 months, you see the cardiac structural as well as functional remodeling, and you see non-transgenic mice and wild-type transgene, which is interesting. Wild-type transgene is the wild-type protein is expressed. Wild-type alpha-beta-cyclin is expressed, like a normal human being. And the humanized R120G was expressed. So what do you see here? Very nicely, the grouping of these gene patterns are somewhat very closer for non-transgenics and wild types, which is forming a big group of these, all these about, we had about like four animals per group, and you can see that all of them are grouping into one group, whereas the R120G is forming a separate group, which indicates that there is a distinction of genetic reprogramming in these hearts at the age of 3 months as well as 6 months. But particularly in 6 months, you can see that pink to strong red, where you can see there is a still further distinction. Majority of the animals, 80% of the animals, have a group with red and the pink at the 3 months versus 6 months. So this is very interesting. So then we went on to see what are these genes mainly. When we looked at these genes very closely, the topmost regulated genes that you could see there are nothing but the antioxidants, which are catalase, GPX1, GSR, G6PD, NQ1, HO1. And all these genes seems to be regulated by a major transcription factor. At that time, like 10 years ago, NR2 was not that much studied in the heart. In fact, our lab was the first one to look at the NR2 AR signaling in the heart. And you can see there is a regulation as a transcription factor, and we were wondering whether the NRT is activated in these hearts. So then we thought that the mechanism, what is the mechanism for reductive stress? Is it all about the NRF2 function? Then we went back and then we proposed a hypothesis that sustained activation of NRF2 AR signaling could be a causal mechanism for reductive stress. Then we could see that the NRF2 in the same setting that you can see before, you saw just now before a couple of slides, where you see that NRF2 is translocating from the cytosol to nucleus of the transgenic mice. So that's the very, very important finding, and which indicates that NRF2 is activated sustainedly. This is at the 6 months. We looked at the 3 months also. The same thing happens, but with higher degree in the 6 months. So this indicates that the NRF2 activation could be a major role. And another thing we noticed that the 3 months and 6 months, what you see here is the immunofluorescence analysis for aggregation. So you can see at the age of 3 months, you can see the aggregates, which these aggregates are very tiny. The yellow colocalized things, green is the alpha-bicursilin, and yellow you can see this. These are the perinuclear aggregates. They are around the nucleus always, and these aggregates getting bigger and bigger at the age of 6 months. So which indicates that you see that there is a age-dependent increase in the aggregation. So meaning that there is a time point at which the protein quality control is impaired. Therefore, at the age of 6 months, these cells are unable to cope up with the aggregates, which are sort of obstructing the cardiac contractility. And that's what we discovered. And interestingly, these are sort of preventing the keep-on association with the NRF2. What happened was these aggregates are more susceptible. The keep-on is more susceptible to get into the sequestered by the aggregates. Thereby, the NRF2 is activated. So there are two mechanisms going on in this. So initially, there is a sort of a mutant protein stress by itself, and over the time, there is a big aggregate which aggregates the keep one also. And I'll tell you the story later why the keep one is so much sequestered into the aggregation, because it has a lot of cysteines, which are theoretically too many compared to the normal protein world. So with that, I would like to summarize the first part of my talk, that mutant proteins activates NR2 signaling, and the sustained NR2 activation leads to reductive stress, and this reductive stress promotes protein aggregation and proteotoxicity. So let us move on to the second part of the thing. Before going to the second part of my talk, there are a lot of questions to be answered. What does the reductive stress can do in biological systems? Do we have any basic evidence? Not only in the heart, not only in the human. Is there any small animals, or is there any other organisms where we could connect the reductive stress? And is reductive stress is protective or detrimental? And another thing, if it is detrimental, is it more harmful than oxidative stress? And also, Rama? Thank you. Thank you. So, and then is reductive stress is harmful than oxidative stress? That's another question. You could remember that in the introduction part of my slide, we had this oxidative stress has natural defense, but we do not know whether reductive stress has it. So this is very important to study then. So now you can see that the keep on NRF2 signaling cascade, as everyone knows that, this is how it works. So keep on association with the NRF2. When it gets dissociated, this goes to the nucleus and binds to the antioxidant response element and promotes the antioxidant production. But this has to happen only in response to stress, not always. This is very important. If you activate the NRF2, people have published thousands of papers on NRF2 protection, which is very important to note that the NRF2 protection is needed only when there is a offense. Only when there is an offense, you need a defense. But if we activate this NRF2, what happens? So we took this opportunity to generate this mouse model. What did we do? Very simple. A mouse model of reductive stress was generated targeting NRF2. This is wild type and the truncated NRF2, which is called constitutively active NRF2, wherein we removed the 89 amino acids which binds to the keep one. Thereby, we made it as constitutively active, and you can see that there is a transgenic low and high depending on the copy numbers of genes that we got, and you see that this is the resulting in dose-dependent binding of NRF2 function to the AREs. And what happened in these hearts? What simply we express the NRF2, overexpress the NRF2 in two different doses, which means that which has too much of antioxidants, including glutathione and other antioxidant proteins at the transcription and translational levels. And what do you see? You see hypertrophy. Merely having taking too much of antioxidants, genetic manipulation of antioxidants is resulting in cardiac hypertrophy. Could you believe this? This is what the novel discovery we just made recently, and this was published last year in antioxidant redox signaling. And you can see the cardiac hypertrophy, the bigger size of the cells. And in addition to that, we looked at the cardiac remodeling, the functional remodeling. What you see is that the speckle tracking is the strain measurements for normal diastolic and systolic functions. As you could see that there is these velocities are completely irregular in the transgenic mice with too much of antioxidants. That's what you see here, that completely diastolic and systolic patterns are completely changed. And blue is the diastolic, wherein diastolic delay is there. This is where we can connect this preserved ejection fraction in these hearts is too much, abnormally increased ejection fraction with delayed diastolic function. So delayed mitral valve parameters. So with that, I would like to show you can see that the pictorial images here in videos that how a normal heart versus the hypertrophic heart. Simply, this is the heart with too much of antioxidants. Now you can think about whether too much of antioxidants are good or bad, because the too much of antioxidants. So meaning that antioxidants are needed only when there are too much of oxidants. Otherwise, they could be detrimental. So with that, I would like to connect you with the human settings. What happens in humans? Yes. So we simply conducted a study with the help of a PhD medical college in Tamil Nadu, wherein we were able to look at the patients, heart failure patients. They were randomly included. Mainly, they do not have any patient. We did not include any patients with major other comorbidities like cancer or diabetes and something like that. But these are all mostly patients with lower ejection fraction. As you could see that there are different ejection fractions are there. There may be some of them are preserved ejection fractions as well. So, and what we see is that there are three different groups. While the normal healthy subjects, you see this range of redox, which is the GSH versus malondialdehyde measurements in their blood plasma. And you can see compared to that, there is one group of 23 heart failure patients falling into the normal redox category, and the other biggest group is the oxidative category, which is 19 out of 50, and we had a subgroup of 8 patients with a highly reductive, which is lower than the normal, meaning that they had too much of antioxidants in their system. So this was our first finding in humans, indicating that the patients are not all heart failure patients have oxidative stress. That's the key point. And in my next slide, you can see, just thinking about combining these small study that needs to be expanded. However, you can see that the heart failure patients with normal redox and heart failure patients with reductive redox is contributing more than 50%. So then if it is more than 50%, how to treat these patients? What sort of treatment has to be given to this? Can we target these patients with antioxidants? That would be a problem. So these patients need a personalized approach. So meaning that nobody can easily, have access to the antioxidant supplements. It has to be a prescribed medication rather over-the-counter medication. That is the goal that we are going to in the near future and in the future we have to aim for, because we believe that the antioxidants must be prescribed based on the redox condition of the given patient. So with that, I would like to draw your attention to these 3 individuals who won the Nobel Prize for 2019 for this slide, wherein you see hypoxia. So these 3 individuals were actively working on. One of them is actually cardiovascular researcher and focusing on the normoxia versus hypoxia. We don't care about hyperoxia because exercise is the one which is increasing your signaling. We believe that too much of antioxidants could kill your basal or basal ROS levels. It could eliminate the ROS levels completely. So we have to be very careful in handling with antioxidants, either genetically or it could be biochemical pharmacological approaches. So, but one more thing, the how we connect this, because there are we recently detected, because of the time I did not show that slide. We detected that some of the reductive patients, we do see that there are mutations, like our animal model. There are mutations in the NEH2 domain that causes NRF2 sustained activation, which results in reductive stress. Therefore, it is very important to look at the genetic screening for these patients, and this gene must be included. In fact, Dr. Rishvi and myself were discussing about this to screen this particular gene mutations in the patients of Indian origin as well. So that would give us more detailed approach of how to personally treat these patients. With that, I would like to, there are so many names, but I would like to highlight I thank that Dr. Ivor Benjamin was my former mentor, and other collaborators and my students, and the great funding support from NIH and American Heart Association and the University of Alabama, Birmingham. So with that, I'm up for questions. Thank you so much.
Thank you, Raj. May I ask a question? Oh, sorry. I thought I unmute. Hi, this is Federica. Thank you, Raj, for the very comprehensive, wonderful presentation. I have a question in regards to the mouse model of A beta crystalline that you showed. And you showed that there is a similar molecular pathways in terms of your Western blot with a significant difference at 6 months in the phenotype. But it looks like you have an increased phosphorylation of A beta in the insoluble perinuclear fraction. Can you comment a little bit more on that? This is very interesting.
Yes, so when we look at the solubility, we took an approach of three different sources of the tissues. Well, I mean, the protein extracts. One is the cytosolic and nuclear extract and a whole cell extract, whole heart actually. So when we compare all these three, we do see that the whole, in every category, we see that there is a dose difference in terms of the amount of aggregates. But interesting enough, we see that the nucleus is not no longer this nucleus, because when we try to extract the nucleus, it came with the nuclear peripheral, all those aggregates. We could not truly separate them. So I believe that it is the matter of like the age point where you see more of the proteins are aggregated while they become 6 months, even beyond, because some of the mice we analyzed at 9 months also, wherein you see that the nuclear aggregates getting bigger and bigger when compared to the lower stage. So what I see here is that there is a better protein quality control mechanisms are activated, or they are taking care of the soluble aggregates, and which might be like degraded or removed from the system, cargo cleaning. But while it becomes bigger and bigger at the later ages, there is a possibility that transition of a impairment in the protein quality control mechanisms. So that's what it is regulating. And we wanted to look at whether is it an autophagy driven, or is it I mean, we do see that there is a protein ubiquitination. A lot of the proteins are flagged with ubiquitin. But truly speaking, that's what our approach is, to look at the proteomics and see like different age points and see the half-life of a lot of these proteins. And that can explain you more. And in particularly talking about alpha-bicrystalline, at the lower ages, the alpha-bicrystalline is very, in terms of the aggregate, it's normally it's a 20 kilodalton molecule. It becomes as big as 800 kilodalton. So meaning that it's not happening overnight, but it happens at the later ages. So that can explain sort of what are the dynamics that we see. But still, I do not have a direct answer for your question. I think that could be answered by the proteomics analysis in deeper.
Yeah, no, that is great. I just wanted to point on the phospho-cryo A beta, because in all the papers that I've read, then there is never focus on the phospho-cryo A beta in the aggregate. So this is something that is interesting in your mouse.
Exactly.
Something in mind, give you some explanations.
Thank you, Freddie. I appreciate that. Let us talk more on that. Additional questions?
I would request the chairperson to kindly introduce the last speaker of the session. Dr. Rajshekhar, am I audible?
Yeah. Okay. I'll take care of Dr. Federica Del Monte.
Okay.
So
Thank you so much.
it's my privilege. Let me stop my screen. It's really a honor to introduce my friend and colleague, Dr. Federica Del Monte. She has a bigger, longer CV that I could not summarize in the next 2 or 3 minutes. So let me brief on her accomplishments. Dr. Fedi is an active physician scientist, and she is well known as the queen of cardio neuro access in our American Heart Association community, for all your information. So with that, Dr. Fedi earned her MD, Doctor of Medicine in Rome, Italy, and she took the cardiology specialty fellowship over there, and then she moved to her PhD to London in Imperial College of Science and Technology, and she earned her PhD in physiology and pharmacology, and then she became a staff cardiologist, clinical cardiologist back in Rome, and then she moved on to Massachusetts General Hospital, Harvard University, for her postdoctoral fellowship. And from there, she grew on various roles, like, starting from her, after the postdoctoral fellowship, she successfully secured career development grants to grow as an instructor, and then as assistant professor, and then to associate professor, and she holds several appointments as visiting professors in different universities, including Italy and Cambridge University as well. And now Dr. Petty is the professor of medicine at the Medical University of South Carolina, and she holds a lot of responsibilities, clinical responsibilities. Director for Heart and Brain Program at which is the Medical University of South Carolina. And Petty is the one who has both heart and brain. People have heart or brain, but she has both, and which is truly driving. She's leading in this field in the national, and she has the national recognition for that. And of course, she received a lot of fundings from American Heart Association and National Institute of Health to take on these interesting novel studies. And particularly, currently she published several papers, over 90 papers, and she has several active fundings, and who in most of them she is a principal investigator, and some of them she is co-investigators. And I'm very happy that she's my colleague, and she also sharing with one of the sub-grants with us to help on the cardio-brain axis. So with that, I would request Petty to present her novel research on HFF and personalized approach to treat these patients. Petty, you're on.
Thank you, Raj. And as you mentioned before, not even my mom would have given me such a nice introduction. And my cat has decided to jump on me right now, which is the proper timing. And let me share my screen. Okay. Can you see my slides?
Yes.
Okay, fantastic. So first, I would like to thank the organizers for having me in this very nice conference, and a conference that is focused on personalized medicine across the different systems, which is something dear to my heart. Because interdisciplinary is what made me curious about some of the aspects that I'm going to describe. And Dr. Karim has given an excellent presentation, and Raj following to help me introduce the concept of the biological phenotype. And some part of proteinopathy. So what I'm going to focus today is to the concept that heart failure, not all heart failures, are made the same. And we began separating heart failures when we realized that not all heart failures have a reduced ejection fraction, reduced pump or systolic function, but some of them have a normal pump function, but an increased stiffness of the heart. And this already calls for a different approach or a different treatment, but we know that the treatment is still mostly the same. And while we understand more about the diseases, therapies actually lag behind. And even within the HFpEF, The HFpEF is the heart failure with preserved ejection fraction, is for the most part associated or causatively linked to hypertension, diabetes, obesity, and some coronary artery diseases. However, there is a subgroup within it that requires probably a little bit more careful focus, and this has been started to be introduced, and thank you, Professor Karin, to do so. And this is the concept of a subgroup of proteinopathies. So proteinopathies are diseases of the proteins, obviously, and the best known of the proteinopathies are, and where they began actually, are the neurodegenerative diseases. And among those, a lot of epidemiological observations show that there are commonalities, at least in the number of patients affected by either of those diseases. And they're surprisingly similar. They affect the same type of patients. They're mostly the senior citizens. And they both end up in a very grim perspective and prognosis, which is chronic disease and death. So, but one step further to that we begin to study is the fact that there is a defect in the ability of the proteins to fold. Let me get the laser pointer. To fold. So we all know that a protein is made as a linear sequence of amino acids, and in order to become functional has to fold. And this folding is a very difficult process for the cell because basically in a linear amino acid sequence, there are a lot of hydrophobic residues that don't really go well along in a 70% water that is the content of the cell. And in this situation, they're really, really chaotic. There's a lot of disorder there, and this comes with a high free energy, which is also called entropy, which is a measurement of chaos. So when a protein is completely unfolded, it's up there in the chaotic stage, and it wants to go to this final native state, where it reaches the minimum chaos for its own protein. And in this protein, it goes through some ups and downs, and this is not an easy process for the cell. It's not a spontaneous process for the cell. It would take forever unless there is a help of the chaperone proteins that help in this process of folding. They shield the protein when it goes in and out in these different shapes from the water. But mistakes happen all the time in a protein that is just per se normal, is brand new. And it also happens if the cell is under stress. And we heard a lot about oxidative and reductive stress, which is associated with aging. And in particular, the sarcoplasmic reticulum is in cardiomyocytes very highly susceptible to oxidative stress because there are a lot of proteins that are calcium dependent, and this leads to oxidative stress. I'm not going into details of that. However, in this situation, the chaperone tried to refold and fix the protein and reshape them. But this is not always successful, and for example, if the stress is too high, or there are mutations where the wrong amino acid is there, there's not going to be any ways for the protein to refold. And therefore, it goes through a ruinous process where it goes through phases of amorphous aggregates, and this is very dangerous because it's very, very chaotic, disorganized, so the energy is altered, and so they want to make it more and more compact to go to a lower energy. And in this process, they will end up in this very organized, nicely parallel structure, which is the amyloid fiber. And the amyloid fiber is when we compact all our garbage there, and we reduce our energy, we reduce the space. And in this process, they go through an intermediate which is very dangerous to the cell. And Raj has already hinted to that in the oligomerization aspects of in this process. This is something that is targeted heavily in neurodegenerative diseases. And what I would like to underline is that in this description, I didn't tell you which protein it is involved because it doesn't really matter. Any protein can lead to that. Any protein can be mutated from the DNA. Any protein can be more susceptible to stress. So there is a concept that is hard to modify, which is that the amyloid is a specific structure from an amyloid precursor protein, and that's that. In the neurodegenerative disease world. In the cardiac world, we've got the cardiac amyloid, which is due to light chain and transthyretin, and the MEG amyloids. But those are not the only ones. And so amyloid is not a disease, is not a protein, it's protein material gone bad. And this is how it's been described actually. It's been described as something that gets a specific color that stains cellulose or starch, which in Latin is amylum. So an amyloidosis is a disease where there is something that precipitates and can be colored with these colors because they just color simply this fiber. But again, we talk to cardiologists about cardiac amyloidosis, and this is what it always comes to our mind, this gigantic amyloid fibers deposit extracellular in the heart, give a restricted cardiomyopathy with all these whitish aggregates visible to the naked eye, and by echocardiography there is this thick restricted heart. What we describe instead is that in patients with a completely different phenotype, which is a dilated cardiomyopathy, we have aggregates in the extracellular space, similar to the Alzheimer's amyloid plaques. And there are some of those fibers inside the cardiomyocytes, similar to the neurofibrillary tangles. But now, these are fibers. These are amyloid fibers, these are amyloid fibers, these are amyloid fibers, these are amyloid fibers, these are tangles. So we don't call the intracellular amyloid, although it is amyloid, because the concept is that amyloid is an extracellular structure, but it's actually not, because no proteins are born in the extracellular space. And important because the medical approach might be different. In fact, the traditional amyloid is not even diagnosed as heart failure. When we see the diagnosis in the chart is amyloid cardiomyopathy. It doesn't say heart failure. And the treatment for transthyretin or light chain, the traditional amyloid, is different. So we may want to think about that even a dilated cardiomyopathy should not be just treated as a heart failure patient with diuretics, beta blockers, and so on. And in fact, here is the therapy that we use for at least two of the main cardiac amyloidosis. And this is not something that we use in any cardiomyopathy and any heart failure patient. In addition to the plaques, we also find in the heart these small oligomers that can be identified with the specific antibodies that recognize the structure of those these specific intermediate. It doesn't recognize an epitope like the regular antibodies, it recognizes a shape, so it's like this little toy, the triangle only goes into the triangle, so this will only recognize the oligos. And those are these little dots in dilated cardiomyopathy, and these are the little dots in the brain of Alzheimer's. And we know that these are very dangerous. So this is where neurodegenerative disease therapy has focused on trying to get rid of the plaques and the tangles and the oligomers. So here we have immunotherapy, try to clear up the oligomers, which is common to all the proteinopathies. But we said that any proteins can lead to that. So when a protein precipitates, it disappears, right? So, or at least there's less available to that. That has a biological consequence. We are missing this particular function. And therefore, we may need to, further, we may need, in this case, a super personalized protein therapy that not only targets proteinopathy per se, but also the specific subclassification of protein that is missing. Mostly like we have different therapy for the transthyretin amyloid and different therapy for the light chain amyloid. This may apply to a subclass of diabetic cardiomyopathy that are now treated with beta blockers, etc., etc. I don't know why my computer doesn't want to go on the next slide. Here we go. So let's fast forward 15 years of research in this field and see what we find in common and where we need to intervene in terms of link between heart and brain. There are genetic mutations that are not only on the same gene, but are exactly the same mutation, found in some cases in Alzheimer's patients, in some cases in diabetic cardiomyopathy patients. And we've been through a bunch of different proteins and we find more and more. And what it looks like is that the same proteins that precipitate in the brain and causing Alzheimer's disease do precipitate in the heart and cause cardiomyopathy. And this may indeed be treated differently. And some of those treatments we already started figuring out. That's what because this is, it's covered by the images, sorry. So some of this we already begin to identify, and so we recently published that in the case of diabetic cardiomyopathy, where we find this particular protein precipitating, we can use hydrogen sulfate, and this is sulfuric acid, sorry, no, hydrogen sulfate. And this is gas and is very delicate and is not easy to administer, but is a way to try to understand that maybe we can modify this treatment to get to these patients. There is why is not going further? There are immunotherapies that have been identified and used in Alzheimer's against the amyloid beta, and it doesn't matter whether there were some that they were treating the fibers, some that were treating the oligos. In any ways, we may need to identify specific treatment for specific proteins that precipitate in diabetic cardiomyopathies. The other aspect is that we know that those aggregates are toxic, so we also have immunotherapies against those. But what I want to focus the attention is one aspect is the unfolding protein response. So when proteins precipitate, the cell is not just there waiting for those things to kill her, but it activates a series of signaling trying to counteract this event. And this is the protein quality control that is divided in two major parts because the brain of human has to divide things to understand it. And one is the unfolding protein response, and one is the ubiquitin proteasome system. So let's look at the ubiquitin and the unfolding protein response. The unfolding protein response starts when proteins accumulates, and here we are talking about the endoplasmic reticulum because particularly in the heart, this is very important because it's very highly susceptible to oxidative stress that induces precipitation, etc. So when this happens, the chaperone proteins that we said are trying to go and fix this problem, but the chaperones under normal conditions are bound to three different effectors. And so when they go and bind to the chaperone proteins, those are free to be activated. And there are three major ones. I'm not going to go into the details, but the effect of this part here, the PERK, is to stop the translational proteins. There is an ER stress, there are too many proteins that are misfolding, let's not add fuel to the fire, let's stop producing proteins that we don't need. There are others, but we need other proteins. We need chaperones. So this path here is going to preferentially induce the translation of chaperones and the other pathways that needs to be activated. So this other pathway here is activated on the acute phase to stop killing the cell. And if we look at the literature, there are a lot of studies on individual aspects of the unfolding protein response. But this is not an isolated event, so everything is activated at the same time and is an integrated system that needs to help each other. And whether something is activated or inactivated and which one and when depends on the intensity of the stimulus, the type of the stimulus, and the duration of the stimulus. So if we have a short ER stress, then those proteins will activate what we described before. But the same exact path are used to activate cell death if the stress is chronic, so the duration is high. So targeting one versus the other can be potentially dangerous. And so we looked at the whole system together in heart failure patients, and we divided them by age because we know that age, as Raj has shown to us, that we accumulate reactive joint species and reductive stress. And what we see is that the chaperones are activated no matter whether it's in the early age or late age, and more in the later age as we expect. The path that leads to the activation of the cell death is activated, but it goes bad with age. So there is an impairment with age, even though it's still activated more than the normal, it goes bad with age. There's a reduction in the path that increases the production of the chaperones and all the proteins to reduce the stress. And this is another reason why we have a potential danger and accumulation of misfolded proteins. The path that activates, that inhibits the cell death is actually inactivated. So we have more cell death because this is a chronic situation we're talking about. These are end-stage heart failure patients. And so there are a lot of therapies that have been used in neurodegenerative diseases or in cancer to activate the unfolding protein response or specific pathways, but we need to be careful because, again, this is an integrated path. And for example, this activator of IR1 increase the risk of cardiovascular diseases because it ends up increasing cell death we may or may not want in specific conditions. And in addition to that, who else are we treating? Who else do we need to treat? And this is where the link between heart and brain has been a little bit confusing because we all accept that if the heart fails and it doesn't pump blood to the brain, there is a reduced cerebral blood flow that starts a series of signaling that leads to the deposit of aggregates. However, the studies show that it's diastolic function that is associated with dementia and not systolic function that is only associated with stroke. And in this case, in HFpEF, by definition, the perfusion is preserved. And if we further look, the distribution of dementia in the HFpEF and the HFrEF cannot be more identical. Perhaps there is more of dementia in the HFpEF population. So we looked at patients with Alzheimer's disease, and this is the work single-handed by Marco and Luca, that show that there is a diastolic dysfunction, which we know with age, but in the Alzheimer's population is worse. And at each step of tertile of age, the Alzheimer's lands halfway through, which means that we know that Alzheimer's is an early or anticipated aging, and we show that there is an anticipated aging of cardiac function, and in particular, diastolic function and HFpEF. And of course, we have to verify that those are actually Alzheimer's cases. So these are the brains of a couple of patients. This is by immunohistochemistry, the traditional staining that they do all the time in pathology. This is not our slide. This is from the web that shows that plaques don't really need to be round, especially by electron microscopy. So when we look at the heart of Alzheimer's patients, we saw these streaks that to me actually when I first saw it could just be collagen deposits. So we did the EM, immunogold EM, and show these little dots are the oligos in the extracellular space and inside the cardiomyocytes. And we can further confirm that by Western blot and ELISA. These are controls. These are Alzheimer's patients. We also added some young controls versus the age-matched controls to Alzheimer's, but there isn't anything in here. There is A beta in the heart and brain from one patient, heart and brain from another patient, positive control. This is for A beta 40. A beta 42 is even worse. And this is being confirmed and quantified by ELISA. So what do we do now? We have a lot of information that things can be different, but we don't really have much of a clue of how many in each and what changes where and when and to whom. So we put together a large group of centers, 3 in Italy, 5 in the US, 2 in the UK, and the group of Tamil Nadu has joined through Raj in this effort to understand the proteinopathy in diabetic cardiomyopathies and Alzheimer's. We need imaging to define whether there is something that gives a clue that we are in the proteinopathy versus non-proteinopathy family, and we already sub-selected some. We need genetic testing if there is a specific gene mutation that we can target. We need biomarkers because we need to understand which protein is going down the road and which and what is the outcome of the UPR, and then we can go to therapies. But until we understand what is going on in those subspecific population, we cannot do a targeted treatment. So with that, this all work that I summarized in 2 slides has been done by a large number of wonderful collaborators and people who work in the lab. I mentioned the work of Marco and Luca, and those are the fellows now in my lab. And of course, the funding agency without whom we cannot do any of the work. And thank you all for listening to this work. Thank you. And hope you're healthy and safe.
Thank you, Paddy. That was a very wonderful work, and as always you do. And now the talk is open for questions. So, Paddy, before other questions, I have a small question about. So, very interesting that particularly look at a given patient. So, is there a way to clinically measure the protein aggregates or any markers for that matter? For example, in your case, both the brain cognitive impairment patients or the heart failure type of patients, there are some connections, right? So, do you think that there is some sort of marker that you could think about?
Yes, actually, there is work ongoing to identify biomarkers in urines and in the plasma because those aggregates are actually circulating. So at least we can define the population of diabetic cardiomyopathy that are proteinopathy from the ones that are not. So diabetic cardiomyopathy, especially idiopathic diabetic cardiomyopathy, they're a big group of a bunch of different things. And there are some that are proteinopathy, there are some that we still don't know what they are, but at least in this subgroup, we can begin treating them like we treat the cardiac amyloid, like differently with specific proteins. And the only way to detect that, there are two ways that we are trying to address with this clinical trial. One is imaging, and one is biomarker. And then, of course, once we sub-select those, the good thing of the heart is that we can biopsy them, and therefore we can identify exactly what protein is precipitated, and because we now have the tools to separate them, as you know, because you do that yourself, to pull them down and mass spec and identify what's in there.
That's right. Thank you so much. So, are there any other questions from audience?
We want to go for dinner.
Pardon me?
We want to go for dinner.
Yeah, maybe everyone wants to go for dinner. I can see the attendance is reducing from 90 to 48. Now, everyone is ready to go home and have dinner. Okay. So now, let me, if there are no questions,
Excuse me, sir. There is a question in the chat section of this Zoom meeting.
Are there any questions? I don't see any questions here.
Yes, there is a question that whether beta aggregates found in brain and heart have same structure, or does it differ in brain and heart?
So, Dr. Petty, there is a question whether beta aggregates found in brain and heart have same structure, or is it differ in brain or heart? Brain and heart.
Whoever asked this question, can she or he come to my lab? Theoretically not, by using a specific antibody called A11, but we are seeing differences in the toxicity level and extent when we purify from the brain versus purify from the heart. Now, whether this is linked to other associated proteins that pull down together with the oligo, or is just the structure itself, we still don't know. We are approaching it two ways. One with molecular, first we need the structure. So we're doing atomic force microscopy to look at size and shape. And the other one, we're doing some mass spec and structural studies to see whether there is a difference there. Also, there's a difference whether these are pure from the brain or the heart, or they are seeded to amplify with the purified protein. So the answer is they may be the same, but they may acquire some slight differences between the two organs that determine higher or lower toxicity.
Thank you, Freddie. I think with that, I would like to, invite Drs. Rubani and Dr. Fatima to conclude the session. Thank you for listening.
Thank you so much.
We had a wonderful session, and all the speakers, they had given an excellent overview of their topics. And definitely in future, the future holds for this precision medicine or the personalized medicine. Whether it's, we have heard about cardiology, but it's true for every branch of medicine that next time that's not so far, then the patients will be coming to us not only with their blood urea, creatinine, RFT reports, but also with phenotype, genotype, and other different biomarkers. So care has to be individualized. So I would like to thank all the speakers. I would like to thank all the organizers, and especially Professor Farzana Mehdi, the Vice Chancellor of Iran University, who had taken this initiative and conducted this talk conference. And I can see our Professor Hari Sharma, and it's nice to see you. And he has always been in academics. He had been to MU also some time back. And thank you, Dr. Raj, for moderating the session excellently. And thank you once again, all the speakers, all the organizers, and the audience. Thank you very much. And I hand over to our co-chairperson, Dr. Professor Jadis Fatma, to please conclude the session.
I would request Professor Hari Sharma sir to, say a few words and conclude the session.
So I think we had a wonderful day today with very high quality lectures. We have heard from United States to Europe, particularly Netherlands, Italy, and also the people joining from Australia, Dr. Lindsay Brown, now he must be sleeping. And obviously all of you, those who were in the hall, as well as online at different places. I would like to thank one and all of you, those who joined. And now I see Gustavo has come from La Paz.
Hello, hello.
From Bolivia.
Good to see you. Wonderful. I am very, very happy to be joining you and to seeing you and to see that you are full of energy and health. And that's wonderful.
Thank you, Gustavo. It is amazing. You know, we will never forget our meeting in Leh. But that time, I had a privilege.
Yes.
I had a privilege to see both of you, your father and you.
Yes, I remember the beautiful beginning of our interaction. Unfortunately, my father has left 5 years ago.
I know.
He is no longer with his neurons here next to me, but I have a daughter that carries his neurons. So we're doing great jobs, great papers together.
Yeah, I think we have communicated, we have texted each other. She was visiting, I think, Denmark or something a few years ago. And
that's correct.
Sure. Wonderful, Gustavo. So nice to see you. And looking forward to listen to you tomorrow, right? Yeah.
Oh, wonderful. Well, I was very stimulated. Unfortunately, as you know, I have the time frame problem. So I'm not able to attend all conferences. But I know. But today, the last 3 talks that I was able to attend were really stimulating. I found them very nice. I'm happy you organized this meeting because it's having a different outlook. And I really think that many interesting ideas will arise from this meeting that you are organizing.
Yes. No, I think your contribution to pulmonary hypertension and the high altitude research is absolutely phenomenal. And India always look forward to have you and listen to you and your contribution and your father's contribution. Now you say that your daughter. So I think you all are doing wonderful. And a lot of people, particularly Venkatesh has been, and many other people from India to your institute as well in Bolivia. So I think
we
had an amazing day
you
today.
all have to come.
Yes, we will come, and you all to Europe as well. You know, we are in a flat land. You are much higher. You know, you are how many 40,000 feet or something? How high is your place?
12,000 feet. 12,000 feet. Yes, 3,500 meters.
My goodness. Well, above sea level. Yeah. No, the Leh meeting was a memorable. Then we interacted in Lucknow as well. You were there.
Yes, I remember that one also. Yes, very nice.
Yeah, unfortunately, we can't be in person to each other, but now online, and this pandemic has really taught us so much different type of lessons, and it's a very different thinking, a way of doing things now is much different than 2 years ago. So I would just conclude by saying few words here today because we had a very long day from 6 o'clock till now it's almost 2. So we have been almost 8 hours full day session. We had a excellent inaugural function that included a keynote talk from Professor Peter van der Speck, who gave a very scintillating talk to address what we are talking about and in relation to the personalized medicine. He also presented a lot of data and also the guidelines or rather the pointers for the future research, followed by various sessions on genomics and this cardiovascular and one more session in between. And I think we have done amazing, kind of covered many areas, but all focused to the biomarkers, molecular diagnostic, and leading to the better treatment, precision treatment or personalized treatment. And there's a lot to do. The future will see much more, patient-oriented, disease-oriented targeting, particularly for that particular patient. So I'm very thankful to all the speakers, particularly the last session, who are present here, Dr. Rabbani, an excellent cardiologist from the medical school and at the AMU JN Medical School in Aligarh Muslim University at Aligarh. And Raj, you did a wonderful, marvelous job in putting together this excellent session, and we look forward to interact and to have you on board in our sessions, and as well as supporting the Personalized Medicine Society. This is a very just 2 years old. I mean, this is our second conference which we are doing, but we hope that in future and by God's grace we would be able to meet. I think you came to our IABS, the Indian Academy of Biomedical Sciences meeting in Trivandrum. So that was, I think, one of the the time when we interacted. And yeah, obviously, Federica, your talk was amazing. Brain and heart, excellent, and huge amount of work and so much coordination you have done. And obviously, we wouldn't be all interacting, sitting together here without the key person who really has been passionately persuading people. I know when we visited ERA, you remember when Mahdi's father was also present that time, is Dr. Farzana Mahdi. She has been, all the time trying to, utilize her expertise as a trained biochemist and trying to bring into the patient care. And I think she's very, must be feeling content today, sitting in the audience and listening so many talks and gaining so much, kind of knowledge in enriching her knowledge in the area of personalized medicine. So thanks to her team, the ERA University, her entire department, which she has created 2 years ago, called the Department of Personalized Medicine and Molecular Medicine, Personalized and Molecular Medicine, which is really fantastic, and they will grow further. We really all wish them, a lot of luck and success, and embark on excellent projects for the future. So I think with these few words, I would like to conclude the day because it's very late in India now. I think it's a dinner time, obviously, and would thank everyone for being part of it. And we look forward for the tomorrow's sessions, which will start in the morning. For me, it is a bit early, but I'll try to join by 5:30 in the morning for me. But I'll try to join from then on and then carry on as much as possible. And I'll see you tomorrow in the last session again.
Sorry for interrupting,
Gustavo.
Hari sir. We
Thank you.
have
Wonderful. Thank you very much. Thank you. Thank you. Thank you.
Bye-bye.
Bye. See you
Oh,
tomorrow.
Lisa also there. Thank
Of
you.
course.
Thanks a lot. Yeah.
Fine. So I'm also waiting for your talk tomorrow, Gustavo, and also for yours, Hari.
All right. Yes, we will. We'll be there. We'll be there. We'll try to satisfy.
Okay.
Excellent. Good to see you all, guys. Yeah. Bye bye. I will stop and. Is that okay?
Thank
The
you so
whole
much. Yes,
the
yes.
people back in Lucknow. Can
Yes,
we
sir.
close it now or?
Yeah,
Yes, sir. Thank you so much, sir.
thank you. Indeed, it was a pleasure to have all of you present your excellent work in this conference. And
I would like to express my gratitude to all the speakers in this session and the moderators, the chairpersons for this session. Hello, Dr. Gustavo, Dr. Vijay Kutala, hello. So with this we come to end, and I would like to sign off. And tomorrow in the morning, inshallah, we'll meet again for a wonderful sessions throughout the day. And tomorrow we're going to have a unique kind of a session in which today we had selected some oral presentations, and the award session went on today. And we have the judges have chosen three best oral presentations. And tomorrow we're going to have e-poster as well as the young scientist. So at 2 o'clock Indian time, we are going to announce the names of the winners for all these, oral, poster, and young scientists in that session. And we are going to play, their presentations also. So that will be a unique session, and I'm sure all the participants, especially the students, the young faculty who have, presented their work in this conference, they all will be there, and of course all of you should be there to listen to their talk and encourage them and bless them. So from 2 to 3 in the afternoon, we'll have this session. If we'll see, maybe we'll just check with our programs, maybe at 1:30 or 2, which we will inform. So thank you very much.
Yeah, thanks a lot.
Thank you.
Yeah, wonderful. The young scientists is the young people. They are the future of everything. You know what we are doing. They will take the flag further. Thank you very much. And the silent listener, Vijay, you were so nice of you. Thank you, dear. Thank you.
Thanks, Hari. Thanks. Thank you a lot. I really enjoyed.
Nice to see you, Dr. Vijay.
Oh, Rashikar. Thank you. Nice talk, Rashikar.
Yeah, nice talking, sir.
Very nice talk.
Hopefully we will meet next year.
Yeah, that's all. Keep our fingers crossed. Okay, so we can sign off now.
Yeah, sure, definitely. Yeah.
Thank you, sir. Thank you, sir.
Good night.
Good night, sir.
Bye. Bye. Bye.
Go.
Oh, pretty.